I would like to introduce our first speaker, Professor Ayman Shaaban, Professor of Surgery, Chicago University. Please, Dr. Ayman. Morning.
Good morning.
Start.
Thank you very much. Thank you very much, and good morning, and glad to see everyone getting out of bed early this morning. I want to talk about a topic that is very important, innovation in fetal surgery, and I'm going to try to squeeze it into 20 minutes, so it will be like a good morning run to get refreshed. So I'll go quickly. The need for innovation in fetal medicine begins with the situation of our patient. Our patients are young, pregnant patients who have a new diagnosis of a complex pregnancy with an anomaly that needs help. All of these patients, they ask the same questions. Why did this happen? Can anything be done to help this condition? And will my child have a normal life? Unfortunately, for the majority of these patients, 90%, we don't have a fetal treatment or cure or anything other than conventional quality postnatal care. This drives the need for innovation. The fetal surgical patient is unique in surgery. The patient herself, the mother, she has no benefits from the operation at all. She only has risks from the operation. All of the benefits are transferred to her baby, as well as risks. So for these patients, we must balance risks and benefits in a different way. Of course, first and most importantly, doing no harm. We must understand that these are vulnerable patients. These mothers will do anything to improve this condition. These are very rare diseases, and there's very little evidence for a lot of the care. And postnatal care is an option. Fetal surgery doesn't have to happen. It's an option for the patient. The innovation must have a minimum of safety for the mother and experimental evidence, at least, for efficacy for the fetus. The essential ingredient for fetal surgical intervention is, does anyone know the essential ingredient? It's the most important one. It's collaboration. None of us have the ability to be able to see all of the blind spots in the care for these patients. So it involves the entirety of maternal and newborn care brought to the patient to develop the best techniques and the best approaches. All of our work has oversight and supervised by a committee of diverse medical background and even community leadership. We have on our committee for oversight former patients, and we have religious leaders, in addition to medical expertise. They guide us, they ensure that we are serving the community correctly, they enforce our ethics policy, and approve our innovation and research. This is the framework with which we talk about innovation. I'm going to give you just a few examples of innovation in different spaces and give you an idea of what we're doing, for example, in fetoscopic surgery for spina bifida, non-invasive surgery for treatment of fetal tumors, and then I'll talk just a few minutes about in utero cellular molecular therapy. Spina bifida is a very difficult disease. It's a disease where we know that the spinal cord is open in the lower lumbar area, but it also has effects in the CNS with hydrocephalus and cerebellar herniation. A disease that occurs before the mother knows she is even pregnant, about 4 weeks of gestation, with a very relatively common incidence, 1 in 1,000 pregnancies in the US. It has multiple causes, and unfortunately, recurrence risk exists. The prenatal diagnosis is well established by ultrasound. Let's see if I can get this to play. Well, the ultrasound will show you the clear diagnosis, no question. And then the treatment is typically after birth. We have an open placode on the baby's back, and the goal is to simply close it in layers to cover the spinal cord and the tissues, the dura as well. Unfortunately, this conventional care leaves the newborn with lifelong disability, varying degrees of neurologic dysfunction, as you see them listed here. And the treatment prenatally is based upon a hypothesis that repair in utero, similar to what we do after birth, will rescue the neurologic function or preserve the neurologic function and reduce the severity. And repair of the defect here in the lumbar spine will help to reverse the CNS changes as well. This was the hypothesis. was tested in 2002 in a formal RCT, the management of myelomeningocele study, the largest study ever performed at the time by the NICHD. It was a very expensive and very long study. It included randomization of 200 patients in either to fetal or newborn surgery. The primary outcomes included neonatal death, the need for a shunt, and motor function at 30 months. I think Dr. Deprest yesterday gave a nice review of this study. The treatment was standardized, the assessments were blinded, and the enrollment began in 2002. It took 9 years to complete this study, unfortunately. The study was stopped early because of improved outcomes in prenatal repair. There was a decreased need for a CSF shunt, was cut in half from 80% to 40%. There was twice the rate of independent ambulation at 30 months of age. Nearly all the patients had reversal of the hindbrain herniation. Of course, there was a higher rate of maternal and newborn complications with fetal surgery. So this is the operation that was performed. It's an open fetal operation. You can see there's a laparotomy here for the mother, and the uterus is exposed. We're making a hysterotomy. Hysterotomy is bloodless and contains and controls the membranes and the myometrium and the uterine wall all together in a controlled fashion. Here you see the surgeon that is closing the neural placode. You can see the opening in the back here, and the spinal cord is open in this area, and the surgeon simply performing a layered closure in about 20 minutes to close the back, and then the fetus eventually stays inside, is delivered, and does well. And you can see the fetus heals very well, but the mother is left with a large uterine scar, a fundal scar. And as such, the mother cannot have a vaginal delivery, no labor for the current pregnancy and future pregnancies. Half of these patients are primigravida mothers, and they're going to have more babies. And as they continue to have cesarean deliveries, their risk for accreta and percreta increase with each one. We require for them for open fetal surgery to wait 2 years before the next pregnancy because of the risk of uterine rupture. Uterine rupture rates in subsequent pregnancies after open fetal surgery are almost 10%. If anyone has seen uterine rupture occur in a patient after a classical hysterotomy, it's a horrible thing to see a young mother become very sick like that. So we have transitioned from open fetal surgery to minimally invasive surgery to reduce the risk. The goal is to reduce morbidity for the mother, to allow her to have vaginal delivery, to reduce the risk of uterine rupture, less accreta, less percreta, and hopefully to improve the efficacy for the fetus, less prematurity and better outcomes for the fetus. So several years ago, we transitioned to fetoscopic surgery. Let's see if this works for us. Good. You can see the fetus here on the inside of the uterus fetoscopically. This is the open placode. Here we're placing the ports, the operative ports in the uterine wall. I'll just skip along here to make it a little bit more efficient. And place the ports here with Seldinger technique. You'll see the port is entered there. And then here's the surgeon dissecting the placode. You can see that the placode is very large in this situation, and you can see that this looks like surgery. It really looks like surgery that you would do with open surgery. And in fact, this is a neurosurgeon who's trained by me to do this operation with us. And the dissection is fine with good magnification and good instrumentation, taking care to preserve all of the nerve roots and avoid injury to the neural placode. You can see we have excellent visualization. Here now we are performing tubularization of the neural placode to close the spinal cord, close the arachnoid. I'll skip along. And now we are mobilizing the dura to perform the next layer of closure of the dura. Here we're mobilizing it with the underlying fascia. Oops, sorry. We're mobilizing it, and we're now closing the fascia and the dura over the placode to provide a strong seal to protect the cord and provide a good watertight closure. Eventually, we now are closing the skin and subcutaneous tissues. There's not enough skin here, so we're going to put a a dermal matrix called the alloderm to replace it. It allows the skin to grow underneath it or through it. And here's the alloderm patch. And eventually just sew it in place. Sometimes we can do primary closure, sometimes we have to do a patch. So I think you understand the idea. So with this approach, we compared our outcomes here for the last 35 cases to the MOMS trial. In the MOMS trial, in these patients with open fetal surgery, vaginal delivery is not permitted. 100% of the patients must have a cesarean delivery. With fetoscopic surgery, 2/3 of the patients are allowed to have vaginal delivery and had a successful vaginal delivery. All the patients except for one that had a cesarean were for indications of breech or repeat cesarean delivery. So this is an immediate success for the patient, for the current pregnancy and for subsequent pregnancies. And the mean gestational age of delivery currently is about the same. We hope with better techniques that this can improve over time. So evaluating our goals, we've been able to reduce maternal morbidity, permit vaginal delivery, prevent and eliminate the risk for uterine rupture for the current pregnancy and subsequent pregnancies, less accreta, and I hope in the future to show you better efficacy. These are the preliminary results we have at this time. We believe it's a safe procedure, and we hope that we're going to have at least equivalent, if not better, outcomes. We'll evaluate that in the future. So neurologic outcomes will obviously take a few years to assess, but this is the baby you saw in the video. You can see the skin patch on the baby's back. This is an L2 spina bifida. I'm sorry, I'll replay that. But you can see the motor function. On the right is you can see the cerebellum is back into the cranium, and you can see the fourth ventricle and reversal of the hindbrain herniation all within the pregnancy. So again, hopefully in the coming years we'll have better data to share with you. Now, looking forward, we've been started to innovate technically what we're doing. One of the things we're doing is actually looking inside the sac before we make the incision in the placode. As you can see here very nicely, you can see the roots coming down. Sometimes the roots, instead of coming straight down, are tracking and sticking to the membranes. And if you make your incision, you will cut the roots and you'll cause injury rather than preserving function. And so we take a quick look on the inside. We can see the nerve roots quite well, and we can do our dissection safely. If the nerve roots are adherent to the membranes, we enter very carefully to avoid damage to the nerve roots. We're also improving our technique for laparotomy. We're looking at the perinatal outcomes. We're looking at the long-term neurosurgical outcomes, developing better instrumentation, research in neuroregeneration, and fetal physiologic monitoring. These are long operations. We don't do a very good job of monitoring the fetal physiology, and that's another area of innovation. I'll just go very quickly here. So we monitor with fetal heart rate for the fetus. That's it. For the mother, oxygenation, arterial line, blood pressure monitors, temperature monitors, everything. For the fetus, just fetal heart rate by an echocardiogram intraoperatively. And when we have situations of cord compression or uteroplacental insufficiency, these are very difficult to evaluate or sort out intraoperatively. We also have no way to measure the fetal temperature during the operation, especially when the fetus is exposed. So we have developed in our laboratory a probe that allows us to look at fetal heart rate, oxygen saturation, and respiratory rate, as well as temperature, dynamically and intraoperatively. We've validated this in a large animal, in a sheep model, and we've looked at transcervical, transthoracic, and transrectal, as well as esophageal placement. Transrectal and esophageal give us the best data. We've developed a actuator that allows us to inflate a balloon to stabilize the probe, to allow us to put it in the fetus. We've compared this to the gold standard for fetal heart rate. We've compared it to echocardiography. You can see the blue is the probe, and red is the echocardiography, and it matches quite well. We compared saturations from the probe to an arterial blood gas from the fetus, umbilical artery gas, and you can see how well it matches up. We've looked at it in situations of cord compression, maternal hypoxia, and hypothermia, and the correlation with the gold standard measurements are excellent. So we're now using this. We've used it in simulated surgery in sheep. You can see the probe there and the actuator, slipping it into the rectum of the fetal lamb. This is a age-matched or size-matched fetal lamb. You'll see the light come up. I'll finish quickly. Yeah. And you can see we have now real-time fetal physiologic monitoring. You can see the saturation, gives a beautiful image, and allows us to do the operation on this simulated operation of spina bifida. Here you'll see this do the operation with full fetal monitoring. So we hope to use this next year in our clinical care. Just talk a few minutes about HIFU, high intensity focused ultrasound, another area of innovation. I think you use this for uterine fibroids and other indications here. Yep. So in the fetal disease, we have a problem of teratomas, large tumors that occur in the chest or sometimes, in the sacrococcygeal area, sometimes CPAMs and other tumors in the chest, or cervical teratomas. These tumors can steal blood and cause an increased cardiac output. You have the babies that have high output cardiac failure as a result, and there is concentric hypertrophy of the heart that leads to this failure. So the only treatment for these patients is either early delivery, or if the patient is too early, we have to do fetal surgery for survival. This is a very morbid operation, and we try to interrupt before the high output failure progresses to high drops. And the operation you can see on the right here is exposure of the fetus and the large tumor. We do a debulking, not quite a surgical resection, but a debulking to remove the bulk of the tumor, control the vascular steal, close the incision, and put the baby back inside. It's a morbid procedure, and it has a lot of preterm delivery. This is what we do when the fetus gets into trouble at 21 or 22 or 23 weeks. We hope to use HIFU to treat these tumors in utero, completely non-invasively. HIFU is an array of maybe 1,000 ultrasound probes focused in an area the size of a grain of rice. It allows us to do completely non-invasive tumor ablation with thermoablation. And you can see our test subject here on the MRI table. It's focused by the MRI and allows very accurate focusing in the area of the tumor to devascularize this tumor sequentially over time. It can be repeated, and it's completely ambulatory. Dr. Christoph Lees at Cambridge is now using HIFU for twin-twin transfusion. Twin-twin transfusion, the bar is even higher because we do this already minimally invasively with excellent outcomes. Dr. Lees is combining very high resolution ultrasound of the placenta and ultrasound guided HIFU for ablation of the vessels. So wonderful approach. We are waiting the data for the clinical study. It's currently in preliminary human study. And then I will just take 2 minutes to talk about cellular and molecular therapy to the fetus. We have a large number of patients that have single gene disorders, like severe combined immunodeficiency disease, Krabbe disease, and osteogenesis imperfecta, and similar diseases. These patients, we do not have any prenatal treatment. Frequently, by the time the baby is born,
either by simple ultrasound guidance
transplantation, which is a potential cure, is so high, it's very difficult, and the regimens are very toxic. So prenatal therapy,
around birth injury,
based upon our ability to diagnose this early, allows us the possibility to provide intervention. And I won't go through this in this particular lecture, but prenatal diagnosis is everything for this. In utero hematopoietic cellular transplantation is a potential therapy where we place the cells early during development, taking advantage of the normal embryologic development for the cells to grow. These are corrective cells, typically from the mother to the fetus, to replace disease and potentially provide a cure before birth. If we can provide these cells in early gestation, the cells that are incorporated are incorporated as self, and there's natural immunologic tolerance for subsequent treatments without any chemotherapy or radiation. This has been applied successfully to severe combined immunodeficiency disease by my mentor more than 25 years ago, but the treatments have since been unsuccessful in immunologically normal patients, primarily because of residual immunologic resistance in the fetus. So we are studying these areas, and I will go quickly through this, but we are using a mouse model as well as a macaque, a non-human primate, and we found that the resistance to the engraftment is based upon natural killer cells. So we're working on immunotherapy techniques, and we'll hopefully have a better clinical trial. My colleagues in Philadelphia are working on in utero gene editing. This is in a preclinical phase right now, and I guess I'm going to have to wrap up pretty quickly. So, but maybe perhaps on a different day we can talk about prenatal gene therapy as well. The board, the organizing committees, the scientific committee for the invitation, the opportunity to come here, and for putting on a fantastic meeting. Thank you very much. Any time for questions?
Now I have the honor to introduce Professor Sharif Abdel Fattah, and his topic should be, should we offer universal screening for PTL?
Thank you very much, everyone. Okay, I'm going to discuss whether screening for preterm labor should be universally offered to everyone, all pregnant women. And I'll just give yourself a few seconds to think about established screening programs, because the first question is what makes a screening program efficient? So things well established like the cervical smears, Down syndrome screening, breast cancer screening, these are well established. And this did not happen haphazard. There was a reason why these were implemented. And the characteristic of an efficient screening program, things to do with the screened condition, the screening test, and what to do when you find it, the intervention. So screened condition, it has to be clinically important, it has to be well defined, and significantly prevalent. And I'm sure you understand the difference between common and prevalent, because common, just common, but prevalent, it means it happens across society, or across all population, to justify testing all population. Also, you need to have known high-risk population, but it's not exclusive, because otherwise you would only target the high-risk population, but it's not exclusive. Think about cancer cervix. We know the high-risk population, but this does not mean it does not happen to younger women. Down syndrome, older women, but can still affect younger women. So we know the high-risk population, but it's not exclusive. Also, you should be able to recognize it early enough. And then what about the test? So you should have a test that people can do. A technique well described, reliable, reproducible. So people can do it in every place, not only the very high specialized, trained who can do it. It has to be reproducible, cost effective, and then you need to have clear cutoffs for suspicious findings. And then you must have an intervention that is available, effective, can be widely implemented, and also cost effective. So let's apply this to the preterm labor clinic, to the preterm labor. Is it worth screening for? Is there a good screening test? Are there reliable interventions? So, is it worth screening for? Do we agree that it's an important condition? I think we do, because the WHO estimates that 1 million babies die each year. It's not only born preterm, but die because of prematurity. It is a global problem. It's not only confined to developing countries. And you can see here again the WHO map of the world showing the prevalence of the preterm birth. And you can see China, United States of America, the two strongest economies in the world, are among the top 10. And on this article here, it's saying that 1 in 10 babies born in the US are premature, which is the same as Somalia. So really, no one is immune, basically. No country is immune, however wealthy they are. Unfortunately, it's a steady problem. We have awareness of it, but we're not managing to reduce. I mean, this graph suggests it's even increasing, not just at least steady, it is even increasing sometimes. It costs a lot of money. I think we all know this, and this is sort of assessment of the annual UK healthcare costs in billions of pounds, and it is like smoking and slightly less than obesity. The consequences are very serious. Of course, we know that intensive care costs a lot of money, and if you're born at 24 or 28 weeks, the baby will need to be staying in the intensive care unit for several weeks, and this costs a lot of money. But it does not stop here, because the care continues later in life with all the consequences of preterm labor. Many babies, depending on their natal unit facilities, will do well, but some will need long-term care. So these are some of the prematurity-related problems, not everything. So it constitutes significant proportion of perinatal mortality, particularly in developed world. 50% of all long-term neurodevelopmental morbidity is a result of prematurity. Cerebral palsy, chronic lung disease, retinopathy, necrotizing vasculitis, intraventricular hemorrhage, all are serious consequences of prematurity that are long-term problems. Okay, do we know risk factors for preterm labor? Yes, we do. There are the usual suspects: the previous preterm labor, genital tract infections, previous cervical surgery, cesarean section at full cervical dilatation, uterine anomalies. But it does not stop here. Lots and lots of studies identifying more and more risk factors. I try to summarize it for you. So, black race, low socioeconomic status, refugees, low education, smoking, drugs, stress, older age, anything really, which just makes you wonder, is anyone not at high risk of preterm labor? To make it even more complicated, more than 50% of preterm labor occur in women with no known risk factors. We all have this woman, we do not know why she started laboring at 30 weeks or 32 weeks. Primary gravida, healthy, young, non-smoker, it happens. And even more than 2/3 of women with traditional risk factors do not deliver preterm. It's a very, very deceiving condition. Let's move to the screening. What can we offer for screening? Just a reminder that the preterm labor is a syndrome, is not just one thing, and there are lots and lots of possible pathophysiology behind it. One of them is cervical insufficiency, another is infection, but there are lots of other factors that are very difficult to understand: hormonal, allergic, genetic. We cannot screen for these, but at least I highlighted the cervical insufficiency and the infection. So what can we offer? We can offer biophysical screening, which is the transvaginal scanning of the cervix, microbiological screening, urine infections, vaginal infections. I'm not going to discuss this today. My focus is on the scanning of the cervix. How do we scan the cervix? I think it is, remember the criteria. Do we have a standard, what to look for? Yes, we do. We know about the cervix, cervical length. It is well described that it's transvaginal scan with an empty bladder. You put some fundal pressure, ask the woman to cuff to look for funneling. You take 3 measurements and you take the best of them. It doesn't have to be the shortest or the longest. The best measurement you're satisfied with. So technique is well described. We know when to do it, between 16 and 26 weeks. Don't do it too early because the cervix is a difficult angle. It's unlikely to measure it short, even in high-risk women. Later in the pregnancy, again, it can be difficult, and it can be sort of normal for gestational age. Some controversy, some questions. Should we draw a straight line, or should we follow the curve of the cervix? Some studies show that it doesn't really matter. So this is same patient here, measuring both ways, and it's very, very similar. Do we know what's normal? Do we know what's abnormal? Yes, there are lots of graphs giving the nomogram for the duration of pregnancy with the gestational age, 50th centile, 5th, and 95th centile. So we know the technique, we know how it can be done, we know what to look for, and we know what's normal, we know what's abnormal. We know what's abnormal. It can be funneling, open internal os, or it can be short cervix with no funneling. This interesting study, it's a bit complicated, this graph, but basically it looked at the risk of delivering early with each sort of different measurements of the cervix at different gestational age. So this is here the percentage of preterm labor on this side, this axis here. These are the different measurements of the cervix, and these are different gestation age. So the dark blue is less than 28 weeks, and then less than 30 weeks, 32 weeks. And as you expect, with the shorter the cervix, the higher the risk of delivering early in the pregnancy. Okay, we applied the screening. We identified a short cervix. Can we do anything about it? Yes, we can. So if the cervix is short, you can offer cervical cerclage, you can offer vaginal progesterone. Again, I'm not talking about infection. That's a different subject with its own controversy. But also remember the other preparations like steroids, magnesium sulfate, transferring the patient for a unit with a more appropriate neonatal unit facilities. And these are equally important in managing these cases because the outcome will depend on where is this baby delivered. Cervical cerclage, I'm sure everyone here is expert, but this case here, we can see a very short cervix with funneling. And then when the sutures applied, you can see the internal os is closed again and the pregnancy carried on till term. Also, vaginal progesterone is equally effective. So we have lots and lots of studies. I just put this one example of a study about vaginal progesterone for preventing preterm birth and adverse perinatal outcome in singleton gestations with a short cervix. So this is no other risk factors, just a short cervix. And I highlighted here that when we assess the outcome, it's important not only to assess the gestational age at delivery, but the outcome. Because if really you delivered at 34 weeks, but you have good facilities and the baby's fine, then that's okay. Better unit, 32 weeks, 100% good outcomes, then that's fine. So what we compare is not only gestational age at delivery, but also the adverse perinatal outcome. And in this study here, it's a meta-analysis here, and it showed clearly that vaginal progesterone improves the sort of delayed gestational age at delivery, but also is associated with better perinatal outcomes. So let's ask this question. Is screening for preterm labor justified? So let's remind ourselves of the characteristics of the screened condition, which is in this case preterm labor. Is it clinically important? Yes, it is. Is it clearly defined? Yes, we all know that the definition is less than 37 weeks. We worry more about less than 34 weeks. Is it prevalent? Yes, 10 to 12%. It's worldwide. It's not only to a special community or a special country or a special category of countries. Is it recognizable early? Yes, with early cervical changes. What about the screening test? The cervical length measurement in this case. Does it fulfill the criteria? Is the technique well described? Yes, it is. Several articles. Is it safe? Some articles actually suggesting it's safe even with preterm rupture of membranes. Do we know what's abnormal? Is there an undefined cutoff? Is it reproducible? Lots of studies showed very good inter and intra-observer variability. Is it reliable? And I would say we have to be careful about this. I would say 60% sensitivity and sensitivity, which is good. Why? Because it's not all one condition, the preterm labor. It's not only cervical insufficiency. There are other factors which will lead to preterm labor, not only a weak cervix or a short cervix. So given the different etiologies of preterm labor, we always have to be aware of this. What about an intervention? Can we do something about it? Yes, we can. Intervention is available, whether it's cerclage or vaginal progesterone. Is it effective? Lots and lots of studies about both of them, comparing with other, like the Arab and pessary and bed rest and folic acid and fish oil and fulu ta'amiyya, whatever. Is it cost effective? Of course it is. We know the high cost and the long-term cost of prematurity. So it is justified to use it. Can they be widely implemented? Yes. Women in this country, they have scans about 20 times during the pregnancy, but everywhere they have at least the 20-week scan. And doing the cervical scan at the same time, so does not mean additional visits. Training is very easy. You don't need really very highly skilled operators. and you don't need specialist equipment. Whichever scan machine you use for your anatomy scan can be very, very efficiently used to measure the cervix as well. And now the important question, does it really work? Can it reduce the preterm labor, or can it at least help? And I would like to remind you of this very important study. It's old now, it's 2011, but it's a very, very landmark study, multi-center study where they applied universal screening for preterm labor for low-risk, high-risk women across multi-center, and they offered them vaginal progesterone for the women with short cervix. It included more than 32,000 women. The transvaginal scan was done at the time of the 20-week scan. Short cervix sort of identified between 10 and 20 millimeter. 2.3% of this population were identified with short cervix. 465 of them agreed for randomization to vaginal progesterone or placebo, which was started from the point of diagnosis up to 37 weeks, or of course, unless delivery or rupture membranes happens. And these are the outcomes. The vaginal progesterone group has significantly lower incidence of preterm labor at various gestation ages, but also about the perinatal outcomes. So lower incidence of respiratory distress syndrome and different composite neonatal morbidity and mortality. We don't have to discuss this in details on this occasion, but collectively the outcomes were much better in the vaginal progesterone group. Another study here, again offering universal screening for, again, all women, and comparing the pre-screen group with the post-screen group, you can see there is significant reduction, statistically significant reduction in the onset of spontaneous preterm birth at less than 37 weeks and less than 34 weeks. So I suggest that preterm labor is a condition that it's worth screening for. Cervical length measurement is a good screening test for preterm labor. It can be applied, and intervention is proved to be efficient. Thank you very much.
I think we will delay question at the end to the end of the session.
Okay, thank you.
Okay. Yes. After the sessions, please. Okay. No, after the session, please.
I have the pleasure to introduce Professor Hatem Musa, Professor of Obstetrics and Gynecology in Leicester University. He will address us about pregnant outcome in women with endometriosis.
Good morning, everyone. First of all, I would like to thank the organizing committee for the invitation, and also Professor Amro for outstanding arrangement. I'm going to talk today about counseling a woman who have long-standing history of endometriosis. Before I start, I would like you to ask yourself what actually you tell that group of women about the obstetric risk. Do you say to them if there is any issues or not? Declaration-wise, I do quite a bit of research, have research from different companies, from tummies, and I literally work in Leicester, and this is the building where I work. Endometriosis has different forms, different types, as okay. Endometriosis has different forms, different types. Unfortunately, for some reason, the slide didn't go back to show you. I don't know how to. No, it's not going. No. Okay. Okay. It's not playing either. Okay. What we know at the moment, how could it affect the pregnancy? Number one, endometriosis could have effect on folliculogenesis and genotoxicity related to oxidative stress. It affected the secretory endometrium. The thickness of the secretory endometrium reduced from 10 to 5 millimeter. It reduced receptivity, progesterone resistance. As a consequence, it affects the placentation and the vascular remodeling, because this is really quite an important issue for placental-mediated diseases. We know that it increased prostaglandin, interleukins, and the cytokines, which could play a role in preterm labor. So the question here at the moment is, what group of women with endometriosis come to your clinic that you should advise them about obstetric risk? So this is here showing you that endometriosis have different forms, but the group we are really interested in are the group stage 3 and 4, women who have a long-standing history of endometriosis and going down the line of IVF and XC, adenomyosis. You seen yesterday outstanding presentation from the endometriosis crew about involvement of the rectum, Douglas pouch, and dissection, bowel and the bladder endometriosis. For those to remind you about the stages, stage 1 and 2 is just a minimal to mild, but stages 3 and 4 is predominantly advanced with deep infiltration. The first time that systematic review brought to our attention the effect of endometriosis came from Zulu et al. In 2017 to say you have to pay attention that women with endometriosis have a higher risk of miscarriage, preterm labor, placenta previa and cesarean section. And when this paper came out, there was some discussion about what group we talking about endometriosis. Is this is the group who have adenomyosis? Is this is the group who have IVF with endometriosis? What actually is we talking about? So they wanted to look into the group who have adenomyosis and another group published immediately the year after, looking on adenomyosis effect. Surprise, surprise, that adenomyosis has a significant effect on miscarriage, preterm labor. But what was interesting coming up as well is a preeclampsia and small for gestational age. This is things start again to bring the attention of other areas. And again, this is the miscarriage rate from the same group, preterm labor, placental abruption, preeclampsia, and all placental mediated diseases were found to be higher in that group. But they looked on assisted conception versus non-assisted conception. And Lalani looked into that, and he found that whether you have endometriosis, you have infertility, you go have IVF, or you have a spontaneous conception, your risk of placenta previa is high. Whether you have that, it also causes preterm birth, but surprise, surprise, it is also associated with increased stillbirth rate, which is an area we never thought about. And so the question at the moment is, do I see that? Usually we have a referral for women with endometriosis to us from the IVF unit when they have advanced endometriosis required surgical intervention. That group of women in particular, number one, large number of them on antidepressant. Number two, they have a long-standing history on multiple painkillers. And that is something really important you have to take in consideration, because both antidepressant and the multiple types of painkillers could have an impact on the development of the baby in the early stage. We do the counseling, we assess the notes. Has this woman had laparoscopic operation with advanced adhesion? because we need to say if she's going to deliver, who should be delivering this woman? Does it need a junior registrar to do it in a private clinic, or should be delivered in a hospital because there is a significant adhesion between the rectum, the bladder, and the uterus? So all this information we collect from the operative notes. We have a discussion with her, and we also look, has she got endometrioma or not? You have to be aware that women with endometriosis coming from IVF, having IVF, have a significant increase of preterm labor, of preeclampsia, of placental abruption, and also there is increased risk of cesarean section and the placenta previa. This is a pregnant woman and got an endometrioma in the pouch of Douglas. And during pregnancy, we assess them for placenta. We assess them for blood pressure. There is a tendency for us to put them on aspirin because the majority of them coming at old age, long-standing history of infertility, assisted conception techniques. And they have regular growth scan for the risk of a small foredate. Intrapartum, there is a risk of postpartum hemorrhage, but also there is a risk of higher cesarean section rate. So please take that in consideration, and also at increased risk of retained placenta. Now, 3 important conditions that coming up, I wanted to bring it to your attention. The first is a bowel complication of endometriosis. For some reason, we have 2 to 3 cases in the last 3 years that women will present with a classic picture of appendicitis, pain in the right iliac fossa around 17 to 18 weeks, is coming up when you go to remove the appendix and you do your histological examination. You found out that they have got endometriosis. If you look on the right-hand side, some women even have problem with perforation of the bowel during a pregnancy and required colonoscopy and resection. So these are important for you to know. The second condition, I only see in 1 case, is spontaneous hemorrhage during pregnancy. This is quite a rare condition, but it presents with acute abdomen, with major internal hemorrhage and fetal deaths in the majority of time. We see ourselves when we do cesarean section, we see endometriotic areas at the back of the uterus, very vascular, bleed at ease on touch. And in that group in particular, the majority of them will have a bleeding coming from the broad ligament, which endometriosis involving is a broad ligament. The last condition I wanted to bring to your attention is endometrioma. We have a false belief that pregnancy improves endometriosis. Probably it will improve the mild to moderate type, minimal invasion. But I will ask you, how many times you've seen a woman with endometrioma had a shrinkage of endometrioma and disappeared? It doesn't happen. In reality, if you look on this systematic review, you will find is that there's a large number of cases it increases in size. It may have complication like infection. It may simulate tumor during the pregnancy. So you have to take that in your consideration when you manage them. Thank you.
Thank you, Hatem. It's a very nice lecture. Now I'm pleased to introduce my dear friend, Professor Muhammad Mumtaz, Professor of Obstetrics and Gynecology, Cairo University, and also he was elected very recently as an honorary member of the Royal College. So very much congratulations. He will address a very important topic in the twins, actually. In cases of twins, we have a lot of cases have a discordant growth. So why and what to do and how to diagnose and how to manage is his lecture.
بسم الله الرحمن الرحيم. برحب بحضراتكم جميعا. I'd like to thank the organizing committee and congratulate them for their 26th annual meeting in our sister university, Ain Shams. Selective fetal growth restriction is a relatively not new disease, but with the increasing incidence of twins in general, and we're seeing more monochorionic twins during the past 20, 30 years. So we're seeing more of the complications of twins more frequently. By definition, intrauterine or fetal growth restriction is failure of the fetus to reach its growth potential associated with increased morbidity and mortality. This is the broader definition. Of course, the pediatricians have their own definition, which is the ponderal index, but of course, we will stick to ultrasound criteria for diagnosis of intrauterine growth restriction. Some facts about intrauterine growth restriction in general: it is associated with about 3 to 10% of all pregnancy, depending, of course, on the cutoff level that you're using, whether it is below the 3rd percentile or the 10th percentile. Perinatal mortality rate is much, much higher than in growth retarded fetus than normally grown fetuses. It is the second leading contributor to perinatal mortality and morbidity, of course, after prematurity. 20% of all stillbirths are IUGR. Incidence of intrapartum hypoxia in cases of IUGR has been reported to be as high as 50%. Early and proper identification of and management lowers the perinatal morbidity and mortality. These are IUGR facts in general. Selective fetal growth restriction, the term may be used in dichorionic twins and in monochorionic twins, but due to the increased risk of complications in selective fetal growth restriction in monochorionic twins, the term usually refers to selective fetal growth restriction in monochorionic twins, although it may happen, of course, in dichorionic twins. The term selective or SFGR in monochorionic twin pregnancy is used to define cases with an estimated fetal weight of less than the 10th percentile in one fetus. So one fetus is IGR, the other fetus is normally grown. And the inter-twin estimated fetal weight difference is above 25%, calculated as the larger twin minus the smaller twin over times 100 over the larger twin weight. This is, of course, is the most agreed or most accepted definition, but some would say that a difference of 20% inter-twin weight estimation is acceptable, although it will increase the incidence. Of course, if you decrease the inter-twin difference, you will increase the incidence of selective fetal growth restriction, but both are accepted. Selective fetal growth restriction approximately affects 10 to 15% of monochorionic twins, and this is compared to half of the cases, which is about 5 to 8% in dichorionic twins. So it occurs in dichorionic twins, but in monochorionic twins, it's more common, and it is more risky with or associated with more complications. Once a diagnosis has been made, a cause should be sought, including detailed anatomy scan, screening for viral infections, and of course, looking for chromosomal or genetic disease. When you have a small baby, small fetus, these are the 3 things that you should do. You should check or exclude viral infections. You should exclude congenital malformations and chromosomal diseases. Then, if both are not present or the 3 of them are not present, then this is a placental insufficiency and fetal growth restriction due to this cause. Amniocentesis sometimes is required to exclude chromosomal abnormality. SFGR results in increased rate of mortality and morbidity, especially among monochorionic twins. Clinical evolution is largely influenced by the existence of anastomosis. We all know that in monochorionic twins, they share one placenta, so there must be some kind of vascular communication. They have already vascular communication. So this weight discordance is usually due to the unequal sharing of the placenta. We all understand that the placenta normally in monochorionic twins is shared equally. Half of the placenta supplying blood supply to one fetus and the other half is supplied to the other. Actually, in cases of selective fetal growth restriction, the smaller fetus takes a small part of the placenta, and the larger fetus takes a large part of the placenta. This is the so-called unequal placental sharing. Selective fetal growth restriction is associated a substantial risk of fetal and neonatal complications for both twins and increased risk of intrauterine fetal death, of course, of the growth restricted fetus and also of the normally grown fetus, as I will show you. It's very important to understand that in cases of dichorionic twins, when you have one fetus that is not growth restricted, you are following up pregnancy. Let's say at 26 weeks, the fetus is severely growth restricted with abnormal Doppler changes. What would happen if you wait for 2 or 3 weeks? The small fetus may even die in utero, but the death of this fetus in utero will not affect the normally grown fetus because both have their own placentas. In cases of monochorionic twins, due to the sharing of one placenta, if you have a small a fetal growth restricted fetus and the other fetus is normal, death of the monochorionic twin that is growth restricted will result in death of the larger twin in 10 to 40%. And this is why, because when this fetus is dying, there is hypotension, there is blood pressure lowering, and the other fetus, due to the vascular communication, will try to salvage the small fetus, will try to save the small fetus. So it will push blood into the circulation of the smaller fetus, leading to hypotension in the normally growing fetus. This hypotension may lead to fetal death. So the consequence of death of a small fetal growth restricted fetus in the monochorionic twin may lead up to 25 or 40% death of the normally grown fetus. Also, this attacks of hypotension may lead to some kind of brain hypoxia. So even if the fetus survived, the normally grown fetus survived, there is an incidence of 15 to 20% of brain damage. So even if both twins survive, small fetal growth restricted is associated with substantial risks for one that is growing normally. Once a monochorionic placentation has been established, the diagnosis requires the presence of 3 important ultrasound findings. First, the estimated fetal weight of one twin measures less than the 10th percentile for the assigned gestational age. So this diagnosis means that you should do 2 things very important in the first trimester. When you have a case of twins in the first trimester, you should do 2 things. First, confirm chorionicity, because later in pregnancy, when the patient is 22 weeks and you try to find if it is monochorionic or dichorionic, sometimes it's very difficult. So in the first trimester, you should confirm chorionicity. This is a monochorionic or dichorionic. The second thing is to confirm gestational age, measuring crown rump length. Usually, if you have twins, you take the longer or the larger crown rump length, and this to confirm gestational age. Because later in pregnancy, if you want to diagnose fetal growth restriction, you have to compare it to the gestational age. And the gestational age best determinant is crown rump in the first trimester. Because prior studies have shown a negligible difference between growth curves for singleton and twin pregnancy, in the second trimester, standard يعني زي اللي هي established by curves by Hadlock for singletons are used to assign growth percentile. There is twins growth percentile, of course, if you want to make it more accurate, but this, of course, you have to refer to. When you have a growth restriction in one twin, the second thing is to assess Doppler changes of the umbilical artery of this fetus. So you look at the umbilical flow, and of course, if it is abnormal, then you look for other Doppler changes like the middle cerebral and the ductus venosus. Finally, the diagnosis of twin-to-twin transfusion syndrome should be excluded because we all know twin-to-twin transfusion also occurs in monochorionic twins, and the criteria for diagnosis of twin-to-twin transfusion is not that one fetus is small and one fetus is normal. The criteria mainly is there is polyhydramnios, oligohydramnios sequence associated with normally grown fetus and small fetus. So to exclude twin-to-twin transfusion in a case of there is a disparity or discordance of fetal growth, you should look at the amniotic fluid. Of course, in all cases of fetal growth restriction, there will be some kind of oligohydramnios. So in the small fetus, you will have diminished life. But in cases of selective fetal growth restriction, due to unequal placental sharing, the normally grown fetus will not have polyhydramnios. It will have normal life. So you will find growth discordance with oligohydramnios in the small fetus and normal amniotic fluid in the normally grown fetus. If you have TTS, you will have a small fetus with oligohydramnios, and then you will have a normally grown fetus with polyhydramnios. This is the criteria for diagnosis of TTS because, of course, there are two different diseases. The problem is that in some cases of selective fetal growth restriction, you will have twin-to-twin transfusion syndrome superimposed on selective fetal growth restriction. So if you have a selective fetal growth restriction, you cannot exclude twin-to-twin transfusion just by saying the amniotic fluid in the normally grown fetus is adequate, is normal. You have to follow up the patient up to 26 or 28 weeks to confirm that twin-to-twin transfusion syndrome did not develop or did not be superimposed on top of selective fetal growth restriction. Because of the blood vessels that link the twin circulatory system together, death of one twin may result in severe drop in blood pressure in the other twin and subsequent brain damage or death, as we said. Diagnosis of selective fetal growth restriction. First, you should confirm chorionicity and amnionicity. It is a monochorionic diamniotic. Then confirmation of the gestational age. Later on, of course, you will look at the fetal weight, and then you will classify the selective fetal growth restriction into 3 types. This was done by Gratakis in 2007, and it is now widely accepted that there are 3 types of fetal or selective fetal growth restriction. The first type, or the type 1, where there is selective fetal growth restriction, you diagnosed it already, but you have normal umbilical artery in the small fetus. Okay, so this is stage 1. Stage 2, there is persistent, this is very important, the word persistent, absent or reversed end diastolic flow. Why persistent is very important? Because there is a third type of selective fetal growth restriction unique to this condition, the so-called type 3. Type 3 is intermittent, absent or reversed end diastolic flow. So if you look at the small fetus with Doppler, you will find sometimes it has a normal flow, and then sometimes it has absent or reversed end diastolic flow. The systolic waveform have a characteristic oscillation reflecting the influence of the transmitted waveform on the peak velocity. This sign is more easily observed at the placental cord insertion during maternal breath holding and using a low sweep speed of the spectral Doppler, which helps to identify not only the diastolic changes, but also the characteristic oscillation of the systolic peak velocity. These changes are the reflection in the smaller fetus cord of the characteristic periodic bidirectional pattern of artery-to-artery anastomosis. So this stage 3 is characterized by artery-to-artery anastomosis, not only artery to vein or vein to artery, but also artery to artery. This artery to artery will push blood in either direction. So sometimes you will find reverse flow or absent flow, and sometimes you will find normal flow. Management of selective fetal growth restriction consists of 4 lines of management. The first is fetal monitoring. The second is fetoscopic laser ablation. The third is selective feticide. And the fourth is intrauterine transfusion. Fetal monitoring is, as we all know, is follow-up. Usually follow-up in these cases is by weekly ultrasound assessment of fetal well-being, amniotic fluid, Doppler studies of the umbilical artery, as well as sonogram to assess fetal growth about every 3 weeks. So follow-up is weekly for fetal well-being and 3 weekly for fetal growth. Early delivery may be decided if the fetal status is deemed non-reassuring based on the fetal heart rate monitoring or ultrasound parameters in the Doppler. The second procedure is fetal or fetoscopic laser ablation. If we look at the placenta, the surface of the placenta in these cases, we will find communicating vessels between the two fetuses. The problem is not that the small fetus is not growing well or taking small part of the placenta. The problem is that if this fetus dies in utero, the other fetus will try to salvage it by pushing blood into its circulation. So the normally grown fetus will suffer from either hypotension with brain affection or even death. So separating the communicating vessels using fetoscopic laser ablation will allow the small fetus to die without affecting the normally grown fetus. It's not treatment to save the small fetus, it is treatment to save the normally grown fetus. This should be done where? Of course, in cases where there is severe Doppler changes in this fetus, the fetus is going to, or possibility of dying within the next 4 weeks, and it's still very early to deliver. Of course, if this happens stage 2 or 3 at 34 weeks, you will not look for intrauterine management, you will look for delivery. But if it happens at 26 weeks, then you will look for intrauterine treatment. So fetoscopic laser ablation is one line of management. The other line of management is fetal cord occlusion, and fetal cord occlusion is simply page is not working. Video is not working. Okay. Cord occlusion is done also fetoscopically through either bipolar or by laser. Simply what we're doing is you are killing the small fetus that is suffering from severe Doppler changes, stage 2 or 3. The problem is once you occlude the cord, of course the fetus will die. But in the same time, the other fetus will not push blood to it if after death. So this will salvage or save the normally grown fetus. The problem with this is that in many areas, and I think here it would make a big controversy about its ethical and religious aspect. The fetus, the small fetus, is suffering. It has fetal gross restriction, it has abnormal Doppler changes, but it's still living. So what you're doing is actually you're doing a feticide in a fetus that is 26 or 28 weeks, trying to save the normally grown fetus. So it is one of the lines of management, but it is a debatable one. I think here أنا مش عارف طبعا إذا كان في حد حاول ياخد فتوى ولا لا, بس I think it would have some kind of a problem in trying to legalize it or find it as an ethical. The other thing is that to do blood transfusion for the suffering fetus اللي هو هيبقى normally grown fetus when the other fetus is dying or hypotension. The problem, of course, of this is a timing. When are you going to time the intrauterine transfusion? It has to be, the fetus has to, or both fetuses has to be continuously monitored so that when you find there is some kind of transfusion from the normally grown fetus to the small fetus, you then push blood into the normally grown fetus. So finally, the take-home messages are: selective fetal gross restriction occurs in 10 to 15% of monochorionic twins. In a recent study, actually, I think last year, the incidence even was suggested to be 20%. It is associated with increase in the perinatal morbidity and mortality of both twins. This is very important. Selective fetal gross restriction can be divided into two groups. Group, which is stage 1, where the fetus is suffering from gross restriction, but it has normal Doppler changes in the umbilical cord. The other group of patients, which is collectively types 2 and 3, the fetus is suffering, whether it is suffering from continuous abnormal Doppler changes or intermittent abnormal Doppler changes. This is to simplify treatment because management of type 1 consists of monitoring, intensive monitoring throughout the pregnancy. If the patient continues as stage 1, then the patient should be delivered usually at around 34 weeks. If the condition transfers into stage 2 or 3, then active management should be done, and active management should be cord occlusion or laser coagulation, fetoscopic laser coagulation. Both therapies seems to increase the chance of survival of the larger fetus with increasing risk of intrauterine demise of the intrauterine growth restricted fetus. Thank you very much.
Thank you very much, Professor Mohammed Mumtaz, for such an excellent presentation. I am so privileged to introduce my friend, Professor Yusuf Abu Ilwan, professor at the University of Zagazig and member of the Supreme Council for promoting 2 assistant professors in OBGYN. He will be shortly talking us about updated recommendations of the Society for Maternal Fetal Medicine in high-risk pregnancy.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه. أتوجه بخلص الشكر والتقدير للأورجنايزنج كوميتي of عين شمس for inviting me in this outstanding event. Actually, I'm going to present the recommendations of the Society of Maternal and Fetal Medicine. This society established now more than 55 years ago. They have about 2,000 specialists in fetal medicine. They arrange every year a conference, and every 5 years they put 5 recommendations. They started from 2014 by 5 recommendations, and then every 2 years they updated this recommendation, and these are the last recommendations which established in March 2021. This is my hometown, Zagazig, and this river told us Prophet Moses was put in it. Okay, this is the first recommendation. All these recommendations don't do inherited thrombophilia evaluation for women with a history of pregnancy loss, fetal growth restriction, preeclampsia, and abruption. We know thrombophilia either inherited or acquired. For inherited thrombophilia, forget it. Actually, the causal association between either methylene tetrahydrofolate reductase and the other one, factor 5 lead-in mutations and protein S and whatever, there is no causal association between adverse pregnancy outcome and this inherited thrombophilia. So don't do it. Only specific testing, if you suspect antiphospholipid clinically, you can limit it to lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein antibodies. Don't place cervical circulage in women with short cervix who are pregnant with twins. Actually, when I read this recommendation, I'm not convinced by it. But this is the recommendation of very strong society. It's like RCOG or ACOG, as I told you, established since 1977. The meta-analysis of this supposed recommendation says that it may be, in fact, harmful. However, the recent update of this recommendation, they withdraw this recommendation specifically after 2 studies which shows that short cervix in twin, it's decreased the incidence of preterm deliveries. If there is time, I will speak, but because of the, I am afraid from running time. Third one, don't make a reversible decision based on the result of cell-free DNA screening test. If DNA screening test tell you this patient has high risk, suppose of Down syndrome, this is not at all means this baby for sure has Down syndrome. It's in spite of sensitivity about 99%. If it tell you it's not, yes, it's not. But this is not still screening test. It's not decisive test. Still screening test in spite of it's expensive, it's high predictive value, still it's screening test. My great professor, Dr. Mumtaz, speak about selective fetal growth restriction, and I'm speaking about, I'm just transferring the recommendation. Don't screen for fetal growth restriction with Doppler flow studies. You can screen for fetal growth restriction from history, from whatever, but don't use Doppler blood flow. I know you will tell me uterine artery Doppler can help us, but what's they mention why you don't do it. Don't screen, don't make it universal. No standard have been established for the optimal definition of abnormal tests, the best gestational age, and the performance of test or technique for its performance. As you see here, diastolic notch or absent diastolic, whatever, don't screen for it. But once you diagnose it, you have to follow it by Doppler blood flow, especially for the umbilical artery. I know Dr. Ibrashi is... okay, next recommendation. Don't use progestins for preterm birth prevention and uncomplicated multifetal gestation. Where is Dr. Sharif? He just mentioned against me. But I'm still, this is the recommendation of this. Don't use progesterone for prevention, but for treatment, yes. Okay. Next one, don't perform routine cervical length screening for preterm birth risk assessment in asymptomatic women before 16 weeks of gestation or beyond 24 weeks of gestation. Yes, if you want to screen preterm labor, restrict yourself between 16 and 24 weeks of gestation. Don't measure the cervix at 8 weeks until it's a short cervix or no. This as long as the patient is not symptomatic. Don't perform antenatal testing on women on just diagnosis of gestational diabetes. Patient with gestational diabetes controlled by diet alone, manage her as normal. The baby of this patient who controlled by diet alone doesn't need additional antenatal test to prevent the fetal death or fetal compromise. It doesn't need, as long as this patient is managed by diet alone, no need to do additional antenatal tests like non-stress test called biophysical profile. Next one, don't place women, even those at high risk, on activity restriction for preventive preterm birth. This is obvious. No one can advise restriction of movement. It's hazardous, of course, more than beneficial. Pregnancy and restriction of fetal movement, you invite the DVT. Next one, don't do serum aneuploid screening after cell-free DNA aneuploid screening has already been performed. What I mean, if you did cell-free DNA screening, don't go backward to do serum screening. Don't do a triple test or quadruple test. It's superior to it. So if the result, whatever the result came to you, don't do the other test. This cell-free DNA will tell you it's low risk or high risk. This test doesn't need complementary test, but still screening test. Don't perform maternal serological studies for cytomegalovirus and toxoplasma as a part of routine perinatal laboratory studies. Don't do, of course, torch screen. And specifically cytomegalovirus or toxoplasma, most of it will come false positive. The other thing, it will cloud your decision and your patient. And only you can do it if clinically or ultrasonography suspected, but don't do it as a routine. Okay, if there is clinically or ultrasound suspicious of maternal or fetal infection. Number 11 recommendation, this one, don't recommend diagnostic testing following sonographic identification of isolated echogenic intracardiac focus or choroid plexus cyst in women with low risk aneuploid screening results. What does it mean? If you do first trimester cell-free DNA the triplet test, quadruplet test, and it came to you negative, and you find this soft marker, which is called cannonball or intracardiac, echogenic intracardiac focus or choroid plexus cyst, you find this is not an indication to do diagnostic test. Consider it. I am not the one who say consider it. They, and I am agree with them, it's a normal variant. As long as, because of your time, these are soft marker came in that era before only we diagnose Down syndrome with the maternal age and these things, and we don't have this cell-free DNA, this choroid plexus cyst. They consider it as normal variant as long as the first trimester or second trimester screening tests are negative. Forget them. Number 12, don't perform serial cervical length measurement following cervical cerclage placement. You find short cervix. You decide to make cerclage. No need to bring your patient and every time you measure the cervix to see where is the stitch. This will confuse you and the patient. Actually, of no value. Simply because of this, no additional treatment option for short cervix after cerclage. You already did cerclage. Why you are measuring after that? Don't do it. Don't test women for methylene tetrahydrofolate reductase mutation. This is, as I just mentioned, or they mention it, as a part of congenital thrombophilia. Don't do it. Because even if it's homozygous, an homozygous individual with this mutation, it's of no value. It's before they recommend it yearly. However, recent studies of more robust design study don't replicate these findings. That's why there is a lack of evidence between methyl tetrahydrofolase genotype should not be ordered as a part of workup of thrombophilia. Don't screen for subclinical hypothyroidism. Subclinical hypothyroidism, the patient doesn't clinically have anything. But you did for her TSH and you find it's high. Free T4, you find it's normal. This is called subclinical. It's found in 2 to 5%. Don't screen for subclinical hypothyroidism except when clinically indicated. Patient have previous history or treatment of thyroid, you can do it. Simply why? There is 2 large randomized controlled trial prospective studies on more than 100,000 of women treated. They took treatment of eltroxin. These patients have subclinical subclinical hypothyroidism, and they find the IQ of their babies after 5 years the same. Those who treat with eltroxin or they don't treat. So don't treat. Not don't treat. Don't screen. Okay. Don't use amniotic fluid index to make diagnosis of oligohydramnios. I think the same result as deepest vertical pocket. However, using amniotic fluid index less than 5 centimeter, it's associated lead to greater number of obstetric intervention without significant benefit. So rely on deep vertical point. It's help. Don't perform routine cell-free DNA for screening of microdeletions. We know use cell-free DNA for diagnosis of aneuploidy, abnormalities in chromosomes. There is something called microdeletions. Those who are work in pediatrics and they know these microdeletions. Actually, we don't know it as an obstetrician, like Cry-Duchat syndrome, DiGeorge syndrome. The predictive ability of cell-free DNA for detection of microdeletion is very low. And not only that, if it's skin positive, mostly they are false positive. Because we don't know this microdeletion, don't order cell-free DNA for microdeletions. This is just to tell you that cell-free DNA has the highest predictive ability of Down syndrome. It's 99%. It's decreased the invasive testing. These are the microdeletions, which most of us, we don't know. But to screen it using cell-free DNA, it's not established, but it's established in aneuploidy. 16, don't perform routine cell, these are still. as I told you. Don't perform routine mid-trimester serum biomarker risk stratification for preterm or preeclampsia in asymptomatic patient. You know, because of your time, these are fetal medicine foundation. You can find it in the website, and you can find the risk for any disease you want. For preterm or preeclampsia, there is a history. Whatever you will fill this, one of these things is the biochemical marker. These recommendations don't use these biochemical markers to stratify. At the end, you can find here, submit the risk factor, it will tell you. However, no need to do these biochemical markers. Expensive and it doesn't add. Running. This is, don't do deliver macrosomic baby who is not diabetic before 39 weeks to avoid shoulder dystocia. Actually, no need. Actually, we will not wait. Deliver before 39 weeks of gestation is not recommended for suspected macrosomia in non-diabetic patient. Because of what? Clinically or ultrasound, macrosomia is not accurate. So don't use it. Don't induce preterm delivery before 39 weeks for for macrosomic baby of non-diabetic mother. This is not applicable here. They tell us patient with a prior lower to previous cesarean section, they can have a trial of scar, like previous one cesarean section. Actually, even patient without scar, we don't give her trial of vaginal delivery. But you can still, they mention it, but I'm not responsible. This is the last one because I know you are maybe fed up with me. Don't perform third trimester group B streptococcus culture in patient with group B streptococcus bacteria during pregnancy. Actually, here we don't use JEPS bacteria screening during pregnancy. But if you do it and you find that the result, significant bacteria, more than 100,000 colony per milliliter, you will treat it. This patient either symptomatic or not symptomatic, this is significant bacteria, JEPS bacteria. It's need treatment during pregnancy. And the recommendation to treat it also intrapartum. The recommendation is what? No additional rectovaginal culture later in pregnancy is necessary. You will do this culture to confirm she has group B streptococcus positive. Whether positive or negative, I have to give antibiotic. This if the patient have more than 100,000 colony of group B streptococcus. Patient who have low or insignificant bacteria group B streptococcus doesn't require treatment during antepartum. However, it needs intrapartum prophylaxis at time of birth. So actually, I find our practice in Egypt, we don't screen group B streptococcus, but we used to give antibiotic whether the patient, we don't know if she is positive or negative. I think, fortunately, we are in the right track without any things. I came to the end. This is a handsome guy in في بلاد الفرنجة. شكرا. Thank you very much.
Thank you, Professor Dr. Yusuf Abu Alwan.
Thank you very much, Professor Abu Alwan.
We'll have the symposium presented by Professor Amr Hosseini in 10 minutes. We'll give this 10 minutes for the speaker and the audience to, if they have any questions, the previous 5 lectures.
My question is addressed to Dr. Ayman. You have a very nice lecture presented. My question is, number one, when do you diagnose open spina bifida in your center by ultrasound? Number two, if we summarize the postnatal picture of the open spina bifida, we have cranial, ventriculomegaly, we have motor and sensory, and we have incontinence. And this incontinence is pronounced mainly urine as well as stool. So, can you exactly tell what is the benefit of the operation concerning these three items?
Thank you very much. These are very good questions. I guess the first question you asked was the gestational age at diagnosis for spina bifida. Our routine anatomy scans in the US are typically performed at 20 weeks. In some states, because of the limitations on reproductive choice, these are being performed earlier and earlier. So we're seeing some patients at 14 or 16 weeks with an early diagnosis. Of course, the most important thing is to confirm the diagnosis because often it is wrong. So typically between 16 weeks to 20 weeks, we're making this diagnosis and we're entering into counseling quickly after that. Your second question was about urinary and bowel incontinence in patients with spina bifida who undergo fetal surgery or don't undergo fetal surgery. In patients without fetal surgery, historically, the treatment of urinary retention has been a story of success and improvement in health and renal function long term. So all of the patients with spina bifida are evaluated in a multidisciplinary clinic that includes urology and nephrology, and these patients are always evaluated for intermittent catheterization, even in the newborn period sometimes. The majority of patients go on and do not require intermittent cath in the newborn period, but subsequently almost all patients require intermittent catheterization to prevent ascending infection. With fetal surgery, these problems don't go away. It's unfortunate. In the initial studies, we hoped that fetal surgery would improve urinary retention and urinary incontinence. We haven't seen that. And we hope in the future to have more information, but that's what we understand right now. The intracranial findings. Yeah, so ventriculomegaly, when we are considering patients for fetal surgery, some of them either have normal ventricles, some have advanced hydrocephalus, and some in the middle. The patients in the prospective study, the MOMS trial, who had no ventriculomegaly, they had the greatest benefit. Very rarely did they develop hydrocephalus that required a shunt if they had fetal surgery. If they did not have fetal surgery, 80% or 75% of them required a shunt by 1 year. The patients with advanced hydrocephalus, they do not have significant benefit from fetal surgery to reduce the need for a shunt. So, and the ones in the middle, about the same as the overall group.
Thank you, Dr. Ayman. Professor Nashar.
When to recommend cervical circulage and when to recommend vaginal progesterone, there is an abuse of use of cervical circulage with no sound indication. And according to the Canadian, they are against this cervical circulage in the recent guidelines.
شكرا دكتور بكر. Lots of studies have reported equal efficiency between vaginal progesterone and cervical circulage. Actually, it's as efficient. We give the patients the choice, pros and cons, benefits, risks. And of course, there is always the human element of sort of the doctor and anxiety. So I have to say, with a very short cervix, less than 10 millimeter, I tend to recommend circulage on no evidence, but just because it's too short. And with the progesterone, you usually use it as a first line, knowing that there is a second line of the circulage if it doesn't work. But when the cervix is so short, particularly if there is a history that increases the risk, I normally sort of tend to recommend circulage over progesterone just because I have no second option if it failed the progesterone. It will be too late to do anything about it. But lots of studies showed comparable efficiency, and actually some suggested that vaginal progesterone is even more efficient than cervical circulage.
To go on with the same theme, patients that you would do circulage, would you give them progesterone afterwards or not? I don't know if there is any real RCT about that, whether you do, I mean, if you have a short cervix like 10 millimeter or 15 millimeter, and you did a cerclage at 20 weeks, you just send the patient home without monitoring of the cervical ultrasound, but also without progesterone, or you would give them as prophylaxis or prevention. I want to know if you have any.
Thank you, Dr. Mutaz. There is no clear guidance on this, as you rightly said. There is no clear guidance. There is no true right and wrong. What I tend is when I put a cervical suture, I repeat the scan after a week, between 1 and 2 weeks. If the cervix is normal and the cervical suture is doing the job, I don't repeat any more scans. I don't routinely give progesterone unless the cervix is still really very short or unless the history is really high risk, but not as a routine after cervical suture.
My question is, Dr. Mumtaz, you have mentioned clearly the selective fetal growth restriction in monochorionic and sometimes the adverse effect of single fetal demise, which is the small. Can you elaborate on the dichorionic? If we have the same problem in dichorionic pregnancy with some discordant growth, what is the situation?
Okay. This is a very good question, actually, but the problem, of course, of the time, in dichorionic pregnancy, the problem would be as if you're managing singleton fetal growth restriction. So the decision to deliver the patient or not will be based on two factors. The first is the condition of the small fetus, how normal or abnormal is the Doppler, and the gestational age. When you have a singleton fetal growth restriction, of course, the decision to deliver early will depend on the severity of abnormal Doppler changes. But you're taking the risk of severe prematurity. When you have a dichorionic twin and you have at 26 weeks, for example, one fetus that is not growing with an abnormal Doppler, if you decide to deliver these twins at that age, then you are suffering the risk of the fetus that is small from growth restriction will have complications, and both fetus from prematurity will have complications. So the decision is usually to deliver the patient early usually in monochorionic twins, 32, 34 weeks. Usually you don't allow them to go further than that. But if you have a severely growth restricted fetus with severely abnormal Doppler at a very gestational age in a dichorionic twin, I would just leave them. I would, at 24 or 26 weeks, if you have a fetus that is abnormal Doppler, the reversed umbilical flow, and the other fetus is doing well, you just follow up the patient, you counsel the patient that this patient might die very soon. Usually nothing happens. Actually, I have seen many cases. There is no risk from the dying or dead fetus in dichorionic twins on the healthy fetus. But still, you have to deliver them early also, because the risk of the other fetus having an unexplained or an intrauterine fetal death at 34 or 36 weeks is high.
Unfortunately, we will have no more questions. Please introduce.
It's my pleasure to introduce our next speaker, Professor Amro El-Husseini, Professor of Obstetrics and Gynecology and Head of Department at Ain Shams University. It's about a very hot subject, a global problem, human papillomavirus infection and its prevention.
Good morning. Thank you very much for coming. It's a day off. It's a national holiday, so thank you for getting up early and coming here to give us the honor and the pleasure to join you. Actually, this is my first time to do a sponsored session, so I possibly will not be very good at it, but I accepted this one and another one due to the fact that they will really impact the health situation in our country and for the gravity of the problem that we are seeing from human papillomavirus infection. Human papillomavirus infection is a very common virus and can cause certain types of cancer. I've been working as the head of the Early Cancer Detection Unit in Ain Shams University. And this unit was founded by our late professor, Muhammad Bayoumi Samour, over 35 years ago. And we are the only unit in this country which was originally designed for screening of cervical cancer through pap smear. For a long time, we used to have pap smear as the primary screening tool and the primary prevention tool for cervical malignancy, but actually this has changed massively. We have a sort of cancer in the cervix that is caused by a known reason. The vast majority of cancers are caused with no reason. We don't know and we don't understand the pathophysiology for the development of different types of cancer, but the situation in the cervix is very different because there is a reason, which is human papillomavirus. The cervix is very unique in the fact that it's easily seen, palpated, screened, smeared, so it makes it feasible to screen the cervix, unlike other cancers in the female genital tract, like the ovarian cancer, which is the most aggressive malignancy in the female genital tract, only for one reason, because it's usually diagnosed late due to absence of symptoms. And usually the ovarian cancer is diagnosed in stage 3C. While with the proper screening for the cervical cancer and the proper prevention, we can eradicate the world, eradicate the cervix from cervical cancer from the world. And this is the initiative by the WHO, is to get a world free of cervical malignancy. There are more than 150 types of human papillomavirus, and there are two types, basically 16 and 18, responsible about 70% of cervical cancer. And there is a very strong evidence linking it to other types of cancer apart from the cervix, which is the vulval, vaginal, anal, penile, and oropharyngeal cancer. If you know that HPV is the second most common cause of oropharyngeal cancer after smoking. There are some types of the human papillomavirus that can cause benign disease and have low risk, that like HPV 6 and 11, and some other types are very aggressive and cause cervical cancer like type 16 and 18, which constitute like 70% of the causation of cervical malignancy. If we look at the natural history of HPV infection, in most cases, after 1 year, the vast majority of the patients will get rid of human papillomavirus. But if the human papillomavirus infection persists over 2 years, there is a possibility to progress to low-grade squamous intraepithelial lesion or low-grade dysplasia. And in 4 to 5 years, it can progress to high-grade squamous intraepithelial lesion. And in 9 to 15 years, it can progress to cervical cancer. So HPV can cause these 6 types of cancer. So if you prevent the HPV infection, you are potentially preventing 6 types of cancer. There is an old belief in this country that we don't have HPV infection, which is totally wrong. And we have a very strong evidence that the prevalence of HPV in our country is almost similar to other countries in the world and similar to other countries in the region. So by preventing HPV infection, we are not only preventing HPV infection, we are preventing cancer in these places. The World Health Organization estimates that the worldwide prevalence of HPV in 2017 is about 12% in women and 21% in men. And if we look at cervical cancer, it is the fourth most common cancer among women globally. In 2020, about 600,000 new cases of cervical cancer and 342,000 deaths worldwide. The routes of HPV infection, because this is a very common question that you will have and you will meet in your clinic. How did I get this infection? The vast majority is through sexual contact. However, the HPV, the virus is stable and can survive on surfaces and can resist treatment, so it can be transmitted by other routes. So sexually, vaginal intercourse, anal intercourse, oral sex, and skin injuries. Non-sexual, theoretically at least, transvaginal ultrasound probes, colposcopes, underwear, childbirth, hand-to-hand contact. And this is possible. And sometimes there is evidence that there could be an auto-infection from another area of HPV infection in the body. So what are the risk factors for HPV infection? Younger age at the first sexual encounter, younger age at the first oral sex, higher number of sexual partners, and tobacco smoking. And this is possibly due to two factors. The first one is the lifestyle, and the second possibility is the reduced cellular immunity. And the risk factors for HPV infection are lower level of education, lack of health insurance and medical supervision, and non-Hispanic Black race, at least in the West. The risk factors for HPV persistence and progression to cancer is infection with high-risk HPV types, especially types 16 and 18. In the immunocompromised patients, like those with lymphomas, and those with systemic lupus, and those who are receiving a chronic treatment with steroids, chlamydial infection, and tobacco smoking. It's estimated that nearly all sexually active are infected with HPV within months to few years of becoming sexually active. And these are facts. We can't deny science. These are facts. I'm not saying that. Statistics are saying that. The vast majority of us will have HPV infection. How vast? Between 80 to 90% of us, of all sexually active human beings, will have HPV infection at some stage of their lives. The vast majority will get rid of the infection within a year, but some will have either HPV persistence or progression to low-grade squamous intraepithelial lesion, to high-grade squamous intraepithelial lesion, or to invasive cancer. The HPV testing is part of cervical screening, and we have to stop here for a while. The classical teaching is that the pap smear is the gold standard for screening and primary prevention. These have changed and have changed massively. In my unit, we've been struggling for a very long time to move from the classical pap smear to liquid-based cytology examination of the pap smear. And what's the difference? Just in brief, because we have just had a workshop to teach people and gynecopathologists in this country how to do liquid-based cytology. The difference is that when you do a pap smear, you do brushing of the cervix, so you have some cells stuck onto your brush or iris spatula, and then you spread them on a glass slide and you examine them. So you are examining cells in a vast field, and it's very difficult unless you are very well trained for years and years to find abnormal cells. Because basically this is not tissues, these are cellular examination. So that's the original pap smear. What liquid-based cytology does is that through automation, instead of examining a football pitch, the whole pitch, you only concentrate the abnormal cells in the center, in an area of 13 millimeters. So the pathologist can easily look and find the abnormal areas. And also, through automation, you get rid of the debris that's present in the sample. So the basic fact and science behind liquid-based cytology is the concentration and limitation of the size of the examined area on the slide. So that will make the examination easier. It's sad to tell you that in my unit for the past 25 years, we have been struggling to bring a liquid-based cytology machine to the unit, which cost around 15 million pounds. And thank God, after all these years, we were able to bring the machine. But this was too late. Because during that time, the world had moved to more advanced form of screening, which is called co-testing, which combines two tests, the liquid-based cytology and the human papilloma virus PCR detection. Because there is no abnormal smears, there are no abnormal cells without the presence of the human papilloma virus. And the idea, if you find the human papilloma virus in the pap smear and you have a normal pap smear report, you have to revise your results. Because by this combination or co-testing, the liquid-based cytology and the human papillomavirus detection, you get more accurate results. But what's amazing, that the world now is moving even away from the liquid-based cytology and limiting the screening to the HPV PCR detection. So we reached our goal, but the train already moved. It didn't move completely. The recommendation of the WHO is that if you are still doing liquid-based cytology, you can carry on and do what you're doing, but you have to introduce the HPV PCR detection as well. The screening for HPV infection to detect precancer and cancer. The screening for precancer cervical lesion involves testing for precancer and cancer among women who have no symptoms. That's the whole idea of the screening. You examine people with no symptoms. That's a screening. And the WHO now encourages countries to use HPV tests for cervical screening, including HPV DNA and HPV messenger RNA tests. But for the diagnosis of invasive cervical cancer, this happens when women present with symptoms. Then she must be referred to appropriate facility for further evaluation and diagnosis. And the diagnosis means you need to take a biopsy. You need to have a tissue. There's a major difference between examining a tissue and examining cells, cytology. Whether these cells are coming from a peritoneal fluid, from a fine needle aspiration, from a follicular fluid in the thyroid, in the cervix, it's much more difficult to examine cells than examining tissues. And there are treatments for some HPV-related health problem. Genital warts can go away with or without treatment by themselves through your body immunity. Pap tests and follow-up as needed can identify problems before cancer develops. But prevention is always better than treatment. And here comes the change, the radical change, that the primary prevention now is not through screening. Because in a country like ourselves, with a very limited resources, and that's the reason why the government here is resisting the introduction of the primary prevention I'm going to speak about, because of nothing, not because of denial of the presence of the problem. They know we have the problem, but because that we are a low income or middle income country. We don't have enough money to screen the whole population. Screening the whole population, for instance, either by pap smear or liquid-based cytology or HPV PCR typing requires a lot of infrastructure and a lot of money. Because for this screening and prevention to be effective, you need to screen all sexually active women. And this is very difficult. It's extremely difficult to do this. So now, instead of doing the screening as a primary prevention, we are moving to a new tool of primary prevention, which is much easier and much cheaper, which is the vaccination. The vaccine is present. The vaccine is available, and the vaccine is very effective. But it's very important how we are going to introduce this vaccine. We cannot introduce this vaccine in our society saying that it's a vaccine for human papillomavirus, a sexually transmitted disease. We cannot do this because this will be not accepted, to say the least. We can't say we are vaccinating against sexually transmitted disease. No, we are vaccinating against cervical malignancy. We are going to protect against cervical cancer and possibly other cancers like vulval, vaginal, anal, penile, oropharyngeal cancer, in addition to cervical cancer. It's important to differentiate between types of HPV because I would like to say that the vast majority will have types that cannot cause cervical cancer, like type 6 and 11. And the genital warts usually appear as a small pumps or group of pumps in genital areas. And I have a lecture later in the day about the art of colposcopy, where I will show you how it all looks under the colposcope. And it's very important to say that 95% of cervical cancer is due to human papillomavirus. It's not transmitting. Small glitch with the technology. So it's very important to understand that the vaccination is not going to treat cancer, and it's not going to treat human papillomavirus. The vaccination is going to prevent the occurrence of human papillomavirus. There are different types of vaccines. We have to say that the HPV vaccination provides strong protection against new HPV infection, and vaccination is prevention and does not cure an infection once you have it. And the HPV vaccine is not used to treat HPV infection or disease caused by HPV. Now, there is a very important point here. If we are going to have a national immunization program for prevention of cervical cancer and possibly other cancer, if we are going to have an HPV vaccination program, who we are going to vaccinate and when we are going to vaccinate. First of all, we can start by vaccinating. If we are having a limited budget, we can start by vaccinating girls. And at what age? Well, the best age is between 11 and 13 years old. And this was my proposal for the government here. This proposal was taken by the highest level of this country, and I met with the Minister of Health in this country, and this was approved. And we had a proposal for the manufacturing of the vaccine in this country. Everything was accepted, but there was one obstacle: the financing of the project. The WHO says a very similar thing, that we can vaccinate before the age of 14. In addition, the company which is producing the vaccine, MSD in this country, in this region, and Merck in the United States, is pushing to a glorious slogan: gender equal or gender equal vaccination. They want males also to be vaccinated, and there is some evidence that the vaccination of the males will add to the protection of the society, because it will cause what's known as herd immunity. And in addition, it will protect the males from other types of cancer, like the oropharyngeal cancer, like the penile cancer, like the anal cancer. It's very important to notice that global HPV vaccination introduction, and this is amazing, 122 WHO member states have HPV vaccination in their national immunization program. We are not among them. Egypt is not among these 122 countries. But let me tell you, some of our neighbors are included in this number. Libya. Libya, during the Civil War, 1916, had introduced the national vaccination program for both boys and girls. Emirates have a national vaccination program. Morocco has a national vaccination program. Saudi Arabia has a national vaccination program. So Egypt still among the minority of countries that's not joining this league of countries that are trying to protect their children from HPV infection and a possibility of other malignancies. And 29 additional countries projecting to have HPV vaccine as a national in the national immunization program. The WHO Director General calls for all countries to take action to help end the suffering caused by cervical cancer. And the WHO strategy in the year 2030 is that 90% of girls should be fully vaccinated with HPV vaccine before the age of 15. 70% of women should be screened with a high precision test at the age 35 to 45, and 90% of women identified with cervical disease, either pre-malignant disease or malignant disease, should be offered treatment. That's the WHO initiative. The Gardasil, which is the product here, but there are other products. The form of Gardasil in this country is quadrivalent. It protects against types 6, 11, 16, 18, but there is cross-reactivity and can offer more protection. And in the recent or in the near future, we are going to have the nanovalent vaccine, which is available in the United States, and the United States and most of Europe have only the nanovalent vaccine. It's suggested to have 2 doses before the age of 14, the first dose and the second dose after 6 months. But there is a very strong evidence now that a single dose suffices. For individuals above 14 years, 3 doses are suggested, 0, 2, and 6 months, and it's given in the deltoid muscle. The cost of the vaccine is reasonable in our country, and if there is a national vaccination program, it can become less expensive. The Gardasil contains 4 genotypes, 6, 11, 16, 18, plus 10 cross protection genotypes, HPV 31, 33, 35, 39, 45, 51, 52, 56, 58, and 59. Gardasil can be used during lactation, but not during pregnancy. It's very important, but those cases who had Gardasil not knowing that they are pregnant, no adverse effects were registered after vaccination. Skip this. Thank you very much.
Thank you, Dr. Professor Amr Hosseini. And I would like to introduce Professor Ayman Abu Noor in the symposium of Novo Nordisk. Liraglutide, 3 milligram, and women health.
Thank you very much. Okay, thank you very much. This is a sponsored session, and this is one of the drugs which I really like because I personally have lost 40 kilograms using this drug. I used to be 152 kilograms. I'm now 112. So I have lost 40 kilograms, which is long. Okay, we have a couple of minutes until it loads. Now, this is a new trend that we have weight loss drugs. We used to have weight loss using diet and exercise. Using diet and exercise, the success rate of diet and exercise to treat obesity is 1 in 125. In women, it is 1 in 250. The success rate of diet and exercise in treating obesity is less than the success rate for the most malignant cancer in the human body. It is an incurable disease. We now are starting to manage it. Even bariatric surgery, we expect recurrence within 4 years for the restrictive types, and the malabsorptive types produce a hell of a lot of problems. So now we are developing very effective weight loss therapy. We're going to start with the GLP-1 analog liraglutide. There are other GLP-1 analogs and there are GIP analogs, and these are the most effective drugs for weight loss and the first line. Should an obstetrician or a gynecologist be allowed to write these drugs? Yes. Gynecologists see more obese patients than dietitians. They see more obese patients than internal medicine. Obesity in Egypt in the females is something around 70%. In females, is around 70%. And it produces a huge number of problems. Okay, now let's start. Now look at the impact of obesity on women's health, PCOS, fertility, pregnancy, and the role of liraglutide. Now, we are one of the top countries in obesity in the world. We are one of the top 10. All the top 10 are in the Middle East except for the United States. It's the only one outside the Middle East. So احنا لينا دور ريادة في الأوبستي. احنا جامدين قوي قوي قوي. يعني خير تمام يعني. Okay, this is the Middle East region عندنا كده. Okay, now these are things which are caused by obesity. All right, we have depression, anxiety, asthma, liver disease, gallstones, infertility, subfertility, PCOS, pregnancy complications, urinary incontinence, joint conditions. We have circulatory disorders, diabetes, thrombosis, and cardiovascular risk along with sleep apnea. We have a huge number of problems. عامله زي في الاسلام يقول لك ايه؟ الكبائر الخمر. ليه الخمر بيؤدي الى كبائر كثيره؟ معايا ولا لا؟ فاحنا عندنا الاوبستي بيؤدي الى بلاوي كتيره جدا. لو بصينا عندنا بالنسبه لنا عندنا infertility, subfertility, PCOS, pregnancy complications, menopause وهكذا. طيب دلوقتي if I lower the body rate هل الحاجات دي بتتحسن؟ Yes. We lower the androgen level. احنا عندنا في مصر كمية الأكني والهيرشوتيزم فلكية. احنا من ضمن الدول اللي عندها أكني وهيرشوتيزم كتير. It lowers the risk of breast cancer. وانا عارفين breast cancer is the main cancer in females. Improves quality of life. بيمنع PCOS. بيمنع الانفيرتيليتي. بيحسن fertility حتى لو أصلا ovulatory. يعني انا ممكن تبقى اوفيولاتري وبرضه ما بتخلفش من الاوبستي. بيحسن اوفيوليشن، بيحسن stress incontinence لدرجه ايه؟ stress incontinence, the drugs for stress incontinence produce only 30% value بينما loss of weight 50%. يعني loss of weight احسن من كل الدراجز من غير كمان السايد افكتس بتاعته. هيقلل ديسمنوريا، هيقلل certain gynecological cancers، وكلنا عارفين obesity بيزود any cancer بالذات endometrial cancer. We have endometrial cancer في الحالة دي. كويس. ايه تاني؟ During pregnancy it can cause diabetes, hypertension, preeclampsia. The risk of preeclampsia العالمي is around 4%. مصر 8.5%. We are double على ايه العالم. يعني احنا عندنا preeclampsia ما شاء الله كويسة قوي. dyslipidemia, endothelial function, back pain. عارفين the most common symptom في الطب is back pain. The most common symptom. طبعا ناس تيجي معانا قد كده. اصل انا عندي fibromyalgia. fibromyalgia مين؟ انت عندك obesity. مين دي اللي fibromyalgia؟ معايا ولا لا؟ تقول لك fibromyalgia ومش عارف ايه، انا بنهرج. كويس؟ بعده preterm delivery, induced deliveries, difficult deliveries. اوكي عندنا tears, C-sections ومشاكلها, thromboembolism. عندنا thromboembolism كتير وكده. على البيبي obesity من غير diabetes is a risk factor for malformations. من غير diabetes. فما بالك كمان لو في ايه diabetes. عندنا trauma, shoulder dystocia, brachial plexus وهكذا. menopause رغم ان المينوبوز theoretically الاستروجين بيتعمل من الفات الا ان menopausal symptoms in obese are worse. رغم ان theoretically they should be better. اوكي. لو بصينا هنا اهو نمسك البي سي او اس in cases of obesity في insulin resistance. We are not uptaking glucose. الجلوكوز موجود في البلاد هيقلل سكس هرمون بايندينج جلوبولين، هيعمل هاي اندروجينز وادي الاكني والهيرشوتيزم. يبقى انا عندي اكني وهيرشوتيزم في الادوليسنت. المشكله في الادوليسنت ان الادويه الانوركسيجينيك دراجز in adolescents are not cleared for use. يعني الناس زمان كان انتوا فاكرين ايام السوبوترامين والميريديا والحاجات دي not cleared for adolescents. حتى الادويه الثانيه الكونتريف والحاجات دي not cleared for use in adolescents. بينما احنا عندنا GLP-1 analogs are cleared for use in the adolescents. كويس. الحاجه الثانيه we are going to exhaust our pancreas very quickly. لما الايستروجين يعلى it will increase androgen. الاندروجين بيعمل excessive recruitment of small follicles، هيزود الانتي مولورين هرمونز. these will block FSH وده هيعمل لي infertility وده المرض اللي احنا عارفينه باسم polycystic ovarian syndrome. Okay. Okay, if we reduce weight, what will happen? هنشوف ايه اللي هيحصل عندنا. Weight loss 5 to 10%, just 5 to 10% will restore normal ovulatory cycles in half the patients. هيحسن البريجنسي ريت، هيحسن insulin sensitivity، هيقلل الانسولين، هيحسن الهاي اندروجين واللور LH. كويس؟ فدي هتعمل الكلام ده، لدرجه ان انا كنت بتكلم امبارح على حاجه تانية. البي سي او اس انا شخصيا I don't give metformin. I give weight loss drugs plus inositol plus vitamins بس. alright؟ يعني الميتفورمين is weight neutral. احنا عايزين حاجه تعمل loss of weight truly. اوكي؟ والجي ال بي 1 analogs في diabetes they are the second line treatment. هما الحاجه الاساسيه اللي هي كمان غير انها بتعالج diabetes وبتعمل weight loss they are cardioprotective and nephroprotective. الاثنين موجودين عندنا. ادي الاوبيستي هنا في جميع الستاديز obesity بيزود the risk of PCO. It will increase the risk of PCO. طيب why there is PCO؟ في genetic factors. obesity 60 to 80% عندهم insulin resistance موجوده، hormonal imbalance موجود عندي. اوكي يبقى عندي infertility، عندي obstetric complications، عندي metabolic syndrome، malignancies، واتكلمنا عن malignancy اللي هو ايه؟ cancer of the uterus. عايزين نقول حاجه the Middle East has the lowest malignancy rate في العالم. We have 30% of the international rate. Why? لأن بنصوم رمضان. فلما بنصوم رمضان الجلوكوز level عندنا is very low. فالانسولين is very low. فالخلايا بتاعت الكانسر have huge number of insulin receptors they die. اوكي؟ حتى عشان كده بره بيعملوا 1 meal a day والintermittent fasting والحاجات دي. فكده بجانب البهارات. لكن الريسك ليه عندنا مش اوطى من كده؟ عشان عندنا اوبستي ودايابيتس. يعني لولا الاوبستي ودايابيتس كان بقينا احسن من كده كمان. طيب لو انا اديت انتي اوبستي ثيرابي الاوفرين فوليوم هيتحسن، الفوليكلز هتتحسن، اللايف بيرث ريت هيتحسن، الريجولار سايكلز هتتحسن، والبريجنسي كومبليكيشنز هتقل عندي. What are the therapies for obesity؟ counseling في المشمش، دايت العنا جربت مليون دايت، فيزيكال اكتيفيتي ما بيخسسش ابدا. alright؟ هو كويس بس ما بيخسسش. سيلف مونيتورنج العنا ممكن توزن نفسها كل 3 دقايق لو عايز مش هتخس برضه. ستريس مانجمنت الاوبستي اصلا عامل ستريس. سليب مانجمنت البيهيفير دول السكسس ريت بتاعهم از 1 to 2%. اوكي؟ يبقى نظام نقول للعيانه روحي خسي وتعالي تهبل. ما انا بقالي سنين بحاول اخس. هو انا ما خسيتش. Pharmacotherapy we start with the orlistat very modest liraglutide or GLP-1 analogs. Okay, then we have the central acting drugs اللي هو anorexigenic drugs. then عندنا bariatric surgery gastric band with sleeve دول success rate for 4 years and we expect to relapse by the year number 4. اما البايباس ليها big problems. Okay. الفولس هوب سيندروم ان العيانه اقول لها نخس، الاكسبكتيشنز هاي، العيانه حاسه انها هتتحسن بسرعه، حاسه انها بالدايت هتقدر وبعدين هتحس كويسه، فبتهبط لان هي بتعمل دايت ما تحسنش. يبقى اذا المشكله عندك انت مش عندها هي. يبقى drug therapy does not cure obesity. لازم ان احنا نكمل الدراجز ونعمل دي مده طويله. طيب what are GLPs؟ هو جلوكاجون لايك بيبتايد. انا هاكل دلوقتي هيطلع GLP. واي؟ عشان يقول للبرين stop eating you're full. وهيقول للبرين stop eating and spend the energy. spend the energy. غير الدايت اللي بيعمل starvation diet تقول لك انا ما باكلش وما بخسش. she's right. ليه؟ لان هي لما بتجوع البرين عارف ان في ايه energy deprivation فما يصرفش. زي بالظبط انا بقول لك ايه، انت خلاص اترفدت من الشغل مش هتاكل خالص، تبطل تاكل، تبطل تصرف معايا. لكن لو انا اديتك ايحاء ان انت هيجي لك فلوس كتير تانية هيخليك ايه تصرف. هنا نفس الكلام. يبقى انا هخلي العيانه تاكل فيطلع هرمون تبتدي تصرف. عشان كده اي لعيب كوره في انترناشونال قبل الماتش 3-4 ساعات بياكل ايه؟ مكرونه. لازم ياكل مكرونه قبلها عشان يطلع GLP يقول لك اصرف الانرجي، ابتدي اصرف الانرجي دلوقتي. عند الغداء هيطلع تاني، عند العشاء هيطلع تاني، يبقى ده نورمال. طيب انا دلوقتي عايز اخس من غير ما اكل، هدي انا GLP فده يبقى طالع على طول فالبرين اتضحك عليه. هو حاسس انه لسه واكل ويصرف، مش كده ولا لا؟ لكن هو ما اكلش ولا حاجه. يبقى إذا I am using the natural satiety hormone to stop eating. Okay? دي كلها effects. It will reduce appetite, increase satiety, and increase energy expenditure. هي دي الفرق بينها وبين الدايت العادي. We are going to use the energy. هنخس عندنا في الحالة دي. طيب. ايه تاني بيحصل هنا؟ When I give it هيروح على الكوكين ادرينالين باثواي. هو الناس المدمنة الكوكايين بيبقوا رفيعين ولا تخان؟ رفيعين جدا. سيمباثو كلنا درسنا عشان سيمباثومايماتيك. لا مش عشان سيمباثومايماتيك. الناس كانت بتستعمل امفيتامينز. كانوا بيستعملوه عشان يخسوا مش كده ولا لا؟ alright؟ ليه؟ لأن this pathway in the brain لما بيحصل كويس بيعمل satiety وبيقلل الفود cravings. alright؟ فكانت الناس بتستعمل امفيتامينز for weight loss وكان الناس اللي بياخدوا كوكين بيحصل كده. طيب ما انا لو شغلت الباثواي من غير ما ادي كوكين ما يبقى كويس مش كده ولا لا؟ يبقى اذا انا هشغل this pathway. And another pathway هي alter the food preference. نسأل سؤال. اي واحد بيخس يروح حاطط قدامه طبق سلطه كبير وراح واكله صح ولا لا؟ خلاص المفروض يكون شبع ما بيشبعش لان البرين ما بيضحكش عليه. الهاي كالوري فود هو اللي بيعجب البرين، اللو كالوري فود ما بيعجبوش. تقعد تاكل سلطه من هنا السنه الجايه هتفضل جعان. هنا بقى هيالتر، كلنا سلطه كاننا اكلنا ايس كريم ماشي، يبقى هيقلل الكريفنج. العيانه دلوقتي البرين اتضحك عليه. We don't have to use high calorie food عشان نقول ان احنا ايه مليانين، فنقدر ان احنا نبقى مستريحين. يبقى we'll reduce energy intake، مفيش cravings، we'll control the eating، وهيخلي الانرجي هتبقى اكتر used، فالبودي فات هيبقى قليل. طيب الكلام ده نشوف الريسك في البريجنسي لما البودي ماس اندكس بيبقى نورمال من 20 ل 25 الريسك زيرو. لما يبقى في malnutrition الريسك اكتر، ولما في obesity الريسك اكتر. يبقى اذا this is our normal BMI. مش بس كده، كل 1 point في البي ام اي بيزيد بنقلل البريجنسي ريت 4%. يبقى مثلا واحده 30 لو عندها الانفيرتيليتي 20%، لما تبقى 35 هتبقى 40%، لما تبقى 40 هتبقى 60%، لما تبقى 45 هتبقى 80%. كويس؟ فوق كده غالبا مش هتعرف يحصل انتركورس اصلا. معايا ولا لا؟ فاذا احنا عندنا ده لوحده هيأثر عندي جامد. اوكي. لو انا lost less than 10% انا بتحسن 50%. لو انا lost more than 10% of weight بتحسن almost 90%. اللايف بيرث ريت بيتحسن. spontaneous conception بيتحسن. مفيش دواء for induction of ovulation بيجيب النتائج دي. معايا ولا لا؟ وكلنا عارفين العين اوبيز، كل واحد فيكم جاله عينه اوبيز خدت اندكشن من هنا للسنه الجايه. كويس؟ فاذا الويت لوس هو اساس الثيرابي عندي. طيب دي ادفيرس ايفكتس، في حاجات جامده جدا، دايابيتس، بريكلامسيا، ماكروسوميا، انفكشن very common، postpartum depression، cesarean delivery. احنا cesarean delivery زي ما قال الدكتور يوسف احنا مش محتاجين تخن، الرجاله بيتعملوا cesarean delivery عندنا. معايا ولا لا؟ فاذا سباينا بيفيدا، حاجات كتيره ممكن تحصل عندنا. دي ميتا اناليسيس. على البيبي بقى، احنا عندنا التشايلد هود اوبيستي في مصر مأساوية اكتر من 15%. alright why؟ جزء منه عشان المذر اوبيز، ده اللي احنا بنسميه fetal programming. تمام ولا لا؟ the mother is programming the baby like mother like son، والاب ملوش دعوه. لو اب رفيع ام تخينه البيبي تخين، هو ده النظام. alright فدي كده هيبقى في انسنت سنسيتيفيتي، بلاد بروفايل، كل حاجات دي هتحصل في البيبي، لدرجه ان احنا عندنا الاوبيستي في الاطفال سبب نمبر 1 بوزيتيف في المذر، سبب نمبر 2 السيزاريان سكشن بيعمل اوبيستي، السبب نمبر 3 قله الرضاعه الطبيعي بتعمل اوبيستي. فاحنا عندنا دلوقتي كل حاجه ماشيه ضد الايه العيانه كده، كل الحاجات دي بتاثر عندنا، بتزود الاوبيستي عندنا. طيب احنا عندنا ده الليروجلوتايد اهو جي ال بي، وعملنا فيه كده بيأثر سنسوري على البرين وبيعمل الحكايه بتاعتنا. لما هديه هيقلل الهنجر، هيعمل فولنس، هيقلل فود انتيك، تشينج ان ويت محترم جدا. كويس. الحاجه الثانيه بيأثر على الفيسرال فات اكتر من السبكوتينيوس فات، وكلنا عارفين الفيسرال فات is more dangerous than الفات العادي. طيب بنكتبه ايه؟ الامريكان كولج قال لك اي واحد فوق 30 بي ام اي فوق 30 او فوق 27 with another comorbidity this is an indication. يبقى اي حد above 30 دايما above 27 لو في another comorbidity. اوكي؟ نقدر نستعمله في التينز كمان من سن 12 سنه. ادي عندي الويت لوس، بنبتدي من هو بيبقى الويت لوس ومينتين around 11% ويت لوس، وقلنا انا الهدف بتاعي 7 ل 10%. anything above 10% is excellent. اي ويت لوس طبعا I'm not a typical case and our weight loss around 30%. this is not typical. طيب حاجة تانية few patients willing هيفضل اكتر من 15% weight loss ربع العيانين. next الجلوكوز level will be normalized والانسولين ريزيستنس هيروح، وده هيحسن البي سي او وكلام. دي ترايلز يعني مش عايزين ان احنا نخش في تفاصيل ترايلز، دي كلها بتبين ان ده المنسول سايكل. المنسول سايكل بيتحسن بالدواء لوحده، الاندروجين ليفلز بتتحسن بالدواء لوحده. طيب سايد افكتس، انا لما ابقى شبعان على الاخر ما اعرفش اكل، ولو اكلت هحس ان انا عايز ايه؟ ارجع. دي ماينور سايد افكتس، فبنبدا الدواء جرادجوالي. كويس. في ناس سالتني امبارح وانا بتكلم عن انوستول، طب ليه انت مش بتحب ميتفورمين؟ لان لو انا اديت ميتفورمين مع ده هيحصل سينرجيزم في السايد افكتس، تمام ولا لا؟ كويس. فانا بدي اينوسيتول اللي ملوش سايد افكتس مع الويت لوس ثيرابي ده، وبنديه جرادجوال، فالسايد افكتس بتبقى قليله خالص. اوكي؟ طيب البن جميله خالص، بنبدا لمده 1 ويك 0.6، 1.2 في السكند ويك، 1.8 ثيرد ويك، 2.4 ويك 4، ثم 3. It's a reusable pen منتهى السهولة. But we do not give it in pregnancy and breastfeeding. pregnancy مفهومة لأن احنا ما نعرفش بيكروس البلاسنتا لدرجة إيه وهيأثر إيه. breastfeeding لأن I don't really want to lose weight during breastfeeding. يكفينا إن اللبن بيخسس كيلو في الأسبوع، يعني لو واحدة بترضع بسنمة هتخس كيلو في الاسبوع من غير ادويه. نبص على بعض الكيسز الجاي. 25 year old هتتجوز بعد 3 شهور، بي ام اي 32، irregular cycles، slight hirsutism، كويس، وبي سي او. ايه البيست ثيرابي بتاعتنا؟ دايت ولا دايت اند اكسرسايز ولا دايت اند دراج ثيرابي؟ طبعا هنخش على دايت اند دراج ثيرابي لان هي العينه شور جربت الحاجات الثانيه. She is 32، اي حاجه فوق 30 is an indication. هل دكتور النساء يكتبه؟ يس. ارحم لها ان انت تكتبه عن واحد بتاع سمنه يكتبه. تخيل انا بتروح لدكتور النساء يكتب لها دواء، انا ده دكتور النساء بتاعي، انا بروح لدكتور سمنه. ما هياش احلى حاجه. alright. طيب ايه احسن؟ اورليستات، liraglutide، central anorexians، herbal others. we prefer liraglutide. this is the first line therapy في الحكايه دي. التارجت بتاعنا كام؟ 7 to 10%، لكن معظم العيانين هيعلوا عن ال 10% عندي في الحالة دي. طيب she has lost weight، نعمل ايه؟ والcycles بقت regular. What should we do? Confirm ovulation and maintain weight loss management ولا stop dieting, stop dying exercise, measure androgens? No, we should continue. لأن if we stop what will happen? We will relapse. We will relapse مرة تانية. ايه البارامترز اللي هتتحسن عندي؟ ال LH والاندروجينز، ليبيد، انسولين، جلوكوز. اوفيوليشن هيتحسن، هتستجيب للعلاج لو احتاجت انها تستجيب للعلاج. اوكي. It's very effective. البي سي او هيتحسن، الاوفيوليشن هيتحسن، الهاي اندروجين هيتحسن، الانسولين هيتحسن ايضا. اللي بعده 17-year-old girl 17 years ممنوع الانوركسيانس قبل 18، يبقى دي ما فيش غير الليراجلوتايد هينفع. Marked hirsutism and scalp hair loss. Obese. And that acne on the face and the back receives isotretinoin. After measuring TSH, prolactin, AMH, 17-hydroxy-PRG, كويس testosterone كده diagnosed as PCO كويس هي دلوقتي obesity hair loss acne hirsutism هنعمل ايه الهاي اندروجينز اللي بيجي من الهاي انسولين ده جزء من المشكله ليها باث واي مش عايزين نخش فيها عشان ما نضيعش وقت فاحنا بالاجانب الكلام ده in addition to the anti-androgen therapy we will address the obesity. addressing obesity مهم جدا هيحسن انسولين هيحسن اندروجين هيحسن سكس هرمون باينجلوبين هيحسن اوفيليشن والمهم قوي السيلف استيم. العينه دي اسهل حاجه ان واحد يضحك عليها ويتجوزها عرفي. دي عرضه لاي حاجه. كويس؟ حد بس يقول لها انت كويسه تمشي معايا ولا لا؟ جه ناس ده ايه؟ حبه ابن البواب. في ايه؟ ما هو انت عشان كل شويه عمالين تقول انت ما حدش يرضى بيكي، ما حدش مش عارف ايه، فلما كلمه كويسه من ابن البواب عايز تتجوز ابن البواب، ما ينفعش. اوكي؟ فاذا السيلف استيم مهم برضه ان انا احاسب. اوكي؟ يبقى it can use it in teens زي ما قلنا. Next. Obese 22-year-old is to be married in 2 months and has come for checkup. She's ovulatory. كويس قوي. As a gynecologist هي جايه تشيك اب هتتجوز بعد شويه. Would you advocate weight loss? Yes. اي حاجه فوق كام؟ 30. لان العمليه مش عمليه ovulation. ممكن يحصل infertility رغم ان احنا عندنا ايه؟ ovulation. يبقى اذا we will address it وطبعا عشان حتى تشتري فستان الفرح وتلاقي مقاس يخش فيها مستريح وايه ما تتعقدش من الفستان. Each unit of BMI هيقلل ال chance of pregnancy by 4%. طيب ليه الاوبيستي هيأثر على fertility؟ Early follicular atresia, too much androgen يعمل atresia. Delayed meiotic maturation, aneuploidy بيزيد. احنا لسه قايلين ان الاوبيستي is an independent factor for malformation. تأثير على الاندوميتريوم، تأثير على الجونادوتروفنز، تأثير على sex hormone binding globulin. طيب. حاجة تانية الماتيريال اوبيستي will change gene expression. الجينز وقفها بالميثيليشن ينشغلها بالهيستون موديفيكيشن. دي هتعمل permanent changes transgenerational. يبقى هتعمل لها مشاكل trans. كم واحد فينا شاف واحدة مليانة دخل له العيادة ببيبي رفيع؟ مفيش. مفهوم دي ولا لا؟ يبقى اذا احنا عايزين نقول ان دايما ان احنا نحسن العيانه دلوقتي كويس. alright؟ يبقى الاوفسبرينج الاوبيستي بيزيد. لو انا خسيت قبل ما يحصل حمل هنحسن اوبيستي by 52%. 41-year-old obese lady عندها stress incontinence. First line and the most effective therapy is weight loss ولا drugs ولا surgery؟ weight loss. ويت لوس. انا كان لسه عندي عيانه من يومين ثلاثه قد كده سنها 66 سنه عندها انكونتيننس لدرجه مش لما بتكح على طول ما من الاوبيستي راحت بتاع المسالك قالت لي يمكن عندك برولابس. هي ما عندهاش برولابس. اقول لها طب لسه هنعمل كده. قلت لها انت لو خسيتي 10% you will be better. يبقى اذا الويت لوس هيجيب نتيجه احسن من الدراجز. كتبنا لها دراجز وخدت دراجز قبل كده. We need to lose weight. يبقى اذا الويت لوس كده up to 70% rate of improvement. الماكسيم لأي دواء is around 30% only. هنستعمله 6 weeks to 6 months ونشوف الأخبار. 54-year-old obese menopausal lady. Severe menopausal symptoms as hot flushes and depression. Is weight a factor? Theoretically وكلنا درسنا واحنا صغيرين ان الاوبيز عندهم higher ايه؟ estrogen. فالمفروض يبقى التأثير بتاع المينوبوز أقل. ده بالعكس ده هم عرضة للاندوميتريال كانسر. Actually السيمتومز are worse. جربها فكر فيها. مين بيتحر أسهل؟ الأوبيز ولا الثين؟ الأوبيز مش كده ولا لا؟ مليان فات والكلام ده. فالهوت فلاشز بتبقى much worse في الأوبيز. هي بتحس بالسيمتومز. مين الجوينت بينز يبقى أكتر؟ الأوبيز مش كده ولا لا؟ يبقى إذا معظم الحالات دي هنلاقي كده is weight a factor. لقينا yes. post menopausal state كمان مع الوقت we are losing muscle. فالميتابوليك ريت بتاعنا عمال بيقل. فكل واحدة بتوصل مينوبوز will increase by 0.5 kilogram per year من غير ما تغير أكلها. من غير ما تغير. She will increase in weight. alright؟ السبكوتينيوس والفيسرال فات هيزيد. السكس هرمون بايندينج جلوبولين بيأثر، وعشان كتير قوي تلاقي واحده لما كبرت ابتدت يطلع لها شعر. الاوبيستي اثر على السكس هرمون بايندينج جلوبولين وكده. لو انا استعملت لها دراجز SSRI SNRI او HRT دول بروموت اوبيستي اصلا. الSSRIs بيفتحوا النفس، فاذا ما هياش حاجه لوحدها ان انا اساعد انها تخس لو هي اوبيز حاجه كويسه. يبقى السمري بتاعنا obesity and overweight rates are increasing worldwide. It impacts very many conditions in gynecology زي ال PCO. هيقلل fertility men and women. Contraceptive measures less effective. Risk in pregnancy للمother وللبيبي بعد كده. Weight reduction 5 to 10% هيقلل الريسكس اللي موجوده. وزي ما قلنا احنا عايزين نقول اخر حاجه it is a prescription drug. يبقى يكتبها مين؟ الأطباء. فبتوع النيوتريشن مش من حقهم يكتبوا. فأصبح مين اللي المفروض يكتبوا؟ احنا. معايا ولا لا؟ هي ماشية واحد بتاع دايت مش من حقه يكتبوا أصلا. فيو كان هيلب هير. روح اللي بتاع الدايت. حاجة تانية عايز أقول حاجة. أي واحدة takes less than 1200 calories per day must lose weight. فاحنا بنقول لها امشي على 900 calories per day وامشي على الدراج and you should be fine. Success rate should be strong. ما دام عملنا كده هنقلل binge eating. Thank you very much. I think we have 2 or 3 minutes. لو حد عنده question او حد عنده تعليق ممكن اسمعه. I have 2 or 3 minutes. هسمع الدكتور وفاء وبعدين حضرتك. اتفضل. ممكن هنا هسمعك حد. ممكن حد يدي مايك هنا؟ هنا وهنا وهنا. بس quickly عشان احنا مش عايزين ان احنا نجور على الوقت بتاعتي. دكتور وفاء.
Thank you, Dr. Ayman. It's a simple question. There is some concerns regarding suicidal attacks and suicidal thoughts, self-harm and acts.
مش في الليراجلوتايد في السنترال انوركسيا.
I believe both of them. I believe both semaglutide and liraglutide, both of them, and it's under investigation, and it should be finished by the European Medical Agency for Medicines. It should end in November 2023.
Okay, لا احنا هنتفق على حاجه. It's very hard ان انا اقيس depression في الاوبيز، لان الاوبيستي لوحدها هتعمل ايه؟ severe depression. تمام ولا لا؟ كويس؟ فلقينا على البيس لاين it's almost the same. اما السنترال اكتنج ممكن. مش كده السنترال اكتنج ممنوع نستعمله قبل 18 سنه، لكن دي واخد ابروفال من سن 12 سنه. alright؟ لو عيان عندها حاسه ان السوسايد تنسي زاد it's okay. We have never seen a single case. I doubt ان مصر شافت كيس من الحالات. حاجه ثانيه في ناس سالني على cancer pancreas. It does not cause cancer pancreas. baseline risk 1. Cancer thyroid does not cause cancer of the thyroid. في ناس سالتي على الجول ستونز. obesity هو اللي بيعمل جول ستونز مش الدواء، لكن الجول ستونز اكتر في العينين دول. اتفضل حضرتك. على فكره اللي عايز يطلع البوث بعد كده يسال it's very good.
شكرا دكتور ايمن. حضرتك هي بتاثر على التايم اللي الاستومك بتاخده عشان تبقى انت لو هنعمل جنرال انستيزيا. قول
تاني.
العيانه بتاخد وقت عشان الاستومك بتاعتها تبقى انت تصوم وقت معين قبل جنرال انستيزيا. بتاثر ولا لا؟
انا اقول حاجه. العيانه اصلا مش بتاكل. alright؟ مش بتاكل. احنا we recommend a 6-hour fast للانستيزيا. تمام؟ لو عايز تخليها 8 hours كان بيها، لكن ما فيش specific recommendation ليها. اوكي؟ شكرا. دكتور شريف. last question. بعد كده اي questions ثانيه ممكن نسمعها على البوث او اخر. دكتور شريف هناك. على فكرة أنا عايز أشجع إن الناس تكتبه، لأن you can write it. It's not a dangerous drug.
My main concern is the possibility of it causing thyroid cancer.
It doesn't.
I just heard what you said, and my problem is that, as far as I could find on the internet, it still has warning
on
the leaflet about the possibility of it causing
That's good. لما الدواء أول ما بيطلع نظامه إيه؟ أي complication لازم تبلغ بيها. لكن لما الدواء يبتدي يستخدم كتير قوي بنلاقي بعد كده نشوف الريت في اللي بيستعمل والريت اللي هو فما بيستعملش. لما الحالات زادت لقوا ان الريت is equal. هو الحقيقة الثايرويد كانسر أصلا زايد في العالم كله. يعني thyroid cancer one of the cancers which is increasing لكن هم ما لقوش increased instance of thyroid cancer في الحالة دي. Okay? Thank you very much. Merci.
طعم حضرتك هتغير العنوان اللي هو العنوان ده؟
نعم.
هتغير العنوان السلايد مكتوب غير ده.
Just a millennium one.
نجمة of endometriosis. ماشي. Thank you very much, Professor Ayman. I have the pleasure to introduce Professor Amr Al-Husseini, the chairman of Ain Shams University, the chairman of Obstetrics and Gynecology at Ain Shams University. He will address us about the NOGS millennium of molecule.
Good morning again, and thank you very much for your presence. This is a sponsored session, my second sponsor session to ever do. And again, it's one of the enigmatic diseases that I consider to be one of my bread and butter in work today, because we do a lot of advanced laparoscopy for different types of endometriosis. But unfortunately for myself and good for the patients, that I expect endometriosis in the coming 10 years to be a medically treated disease. Same like many of the diseases that we used to treat surgically, we are now shifting to medical interventions, and endometriosis is one of them, I expect. There are three major types of endometriosis, as you all know. We have superficial or peritoneal endometriosis, ovarian endometriosis, was sometimes called OMA or endometrioma, and deeply infiltrating endometriosis, which most commonly treated by advanced laparoscopic interventions. Endometriosis is a painful disease. The hallmark of endometriosis is pain. So the patients usually come to complain from either severe dysmenorrhea, dyspareunia, dyschezia, pelvic pain, bowel symptoms, in addition to GIT upset. And for some time, these patients usually go to other specialties like gastroenterologists and bowel surgeons seeking consultations, and it may take them a long time before they meet an experienced person in endometriosis to try to solve their problem. In addition to pain, there is usually infertility due to the impact of endometriosis by mechanical methods and its effect on the ovarian reserve. What causes pain in endometriosis is not fully understood, but it may be related to growth factors and cytokines, the leakage from endometriotic lesions, and nerve irritation by endometriotic implants. The medical management of endometriosis is very interesting because there have been a lot of medication that have been tried for the treatment of endometriosis, but we usually prescribe the first-line medications, including oral contraceptive pills and progestogens. And the second line include usually GnRH agonists and medicated intrauterine devices, in addition to NSAIDs, aromatase inhibitors, and danazole, which I doubt any of you is using nowadays. The treatment of endometriosis-associated pain, usually we start by NSAIDs and hormonal treatment, and the recommendation is that women may be offered NSAIDs, non-steroidal anti-inflammatory, or other analgesics, either alone or in combination with other treatment to reduce endometriosis-associated pain. It's recommended to offer women hormone treatment either OCPs, progestogens, GnRH agonist, or GnRH antagonist as one of the options to reduce endometriosis-associated pain. Endometriosis pain is really excruciating, is really debilitating, and many of these women quit their jobs, quit their marital life because of the pain associated with endometriosis. So for patient with pain, we have several options: NSAIDs and analgesics, hormonal treatment, and surgery. For the options for hormonal treatment, these are weapons, our armamentarium: combined hormonal contraception, progestogens, GnRH agonists, antagonists, and recently aromatase inhibitors is coming into the picture. It's recommended to prescribe women with progestogens to reduce endometriosis-associated pain, and the recommendation group recommends that clinicians take the different side effects and different side effect profiles into account when prescribing progestogens for endometriosis. When is the medical treatment required? It's usually the first-line treatment. Also, after surgery to reduce recurrence, and when surgery is not possible or refused. Many of us will face patients who had 3-4 laparotomies before. Midline laparotomies, transverse incisions, and the patient is very obese and risky. And in this situation, you don't want to risk doing another surgical intervention. Many of us had patients who is refusing to have surgery, either because she had surgery before and it didn't help her, or because she's afraid of the complications of the surgery. Many of our patients had heard stories about the complications with endometriosis surgery, the frequent bowel injury in such advanced surgery, what happened to different high-profile social media influencers and actresses during her endometriosis surgery. So many of the patients are afraid to undergo surgery nowadays. The other thing is those patients who had surgery and this was followed by quick recurrence of endometrioma. We see that very frequent. You've done the surgery, you removed the cyst wall, but 6 months later, you see the patient and she's not symptomatic yet, and you do an ultrasound and you find a similar endometrioma in the ovary. So what to do? We nowadays prescribe progestogens for reducing the recurrence of endometrioma after surgery. For pain management, these are the main prescription drugs that we give our patients: non-steroidal anti-inflammatories, oral contraceptive pills in a continuous manner, progestogens, danazole, GnRH agonist and add-back therapy, and also we sometimes prescribe opioids, tricyclic antidepressants, selective serotonin reuptake inhibitors. And recently I have a patient from Kuwait. She was on opioids for the past 2 years because of endometriosis. And this patient had previously had 4 surgeries for the management of her pain, and nothing had helped her whatsoever. We have also the dilemma whether when you have a patient with clear symptoms of endometriosis, like dysmenorrhea, dyspareunia, whether to do a diagnostic laparoscopy for her or to start treatment. This is usually a question that cross your mind. Would you go for a diagnostic laparoscopy, or is it a sufficient approach to do an imaging technique? For endometriosis, not the average sonographer who can take a decision to diagnose endometriosis. And usually you need somebody who had some specialty training in endometriosis imaging, whether by ultrasound or by MRI. For the past 2 years, we have the privilege of working with a multidisciplinary team from different specialties, with bowel surgeons, endometriosis imaging specialists, either in MRI or ultrasound, with pain specialists and neurosurgeon to manage properly the problem of endometriosis. And we found a great discrepancy between those who do a dedicated endometriosis imaging and those who do just general imaging, whether MRI or ultrasound. So we really need somebody who is very experienced in endometriosis imaging. My impression is that if you have somebody with clear symptoms of endometriosis and with the help of experienced imaging physician, you can start the first line of medical treatment for patients with suspected endometriosis. And the conclusion was that both diagnostic laparoscopy and imaging combined with empirical treatment, hormonal contraception or progestogens can be considered in women suspected of endometriosis, and there is no evidence of superiority of either approach, and the pros and cons should be discussed with the patients. So it's a good option if you have a good sonographer and you have good symptoms to suggest endometriosis to start treatment. Now, we are discussing the specific endometriosis therapy with Dynogest, 2 milligram once daily tablets. It has a clinical proof that it's highly effective for pain relief, significant lesion reduction, and favorable safety and tolerability profile. The therapeutic effect of Dynogest in endometriosis, it has a central effect as it reduces both the FSH and LH, and also it has a local effect. And as we know, estrogen causes proliferation of endometriosis, inflammation, and angiogenesis. And so this is the mechanism of action of Dynogest in the treatment of endometriosis: reduction of serum estrogen level, immunomodulation effect, anti-inflammatory effect, decidualization and atrophy of endometrial tissue, inhibition of matrix metalloproteinases, and anti-angiogenic effect. There is marked effect of Dynogest on the symptoms, especially dyspareunia, diffuse pelvic pain, dysmenorrhea, and premenstrual pain. And even in the long-term studies, the effect was maintained for a very long time, up to 65 months. And this is a comparative study between GnRH agonist and Dynogest regarding the reduction of pain. They are almost similar. One remarkable thing is that the effect of GnRH agonist on the level of estrogen is marked in comparison to Dynogest, and that's why the patient who are put on GnRH agonist have a severe menopausal symptoms. And again, a comparison between the change in bone mineral density in both groups. So that's why you need to have an add-back therapy in patients who receive GnRH agonists for a long time. You have to add something like tibolone in addition to calcium and vitamin D. It's a must. Another comparison regarding the hot flushes. The hot flushes are much less with Dynogest. So the conclusion, the efficacy of Dynogest is equivalent to GnRH agonist, but the safety profile of Dynogest is superior to that of GnRH agonist. There is less impact on estradiol level, no increase in hot flushes, and lower incidence of other hypoestrogenic effects, and there is a stable bone mineral density, and there is decrease in the frequency of bleeding events over time. That's why some people will use Dynogest now to treat intractable abnormal uterine bleeding. And this is another comparison regarding recurrence rate. And this study had shown that with Dynogest, the recurrence is much less. And the impact of Dynogest after laparoscopic surgery, there is markedly less tendency for recurrence with Dynogest. So the conclusion, Dynogest 2 milligram has been developed specifically for the treatment of endometriosis through a comprehensive study program. The efficacy of Dynogest 2 milligram, it's effective for reducing the pain related to endometriosis, including dysmenorrhea, premenstrual pain, dyspareunia, diffuse pelvic pain. It's significantly superior to placebo. It's equivalent to the current standard therapy GnRH agonist. It's effective in reduction of endometriotic lesions, and also Dynogest 2 milligram inhibits ovulation reliably. So you can assure your patient who is not desiring pregnancy that this is an efficient tool also for contraception. There is no significant hypoestrogenic side effects, such as decrease in the bone mineral density and menopausal symptoms. Bleeding decreases with continuous treatment, and there is no clinically relevant androgenic effect and no negative impact on lipid profile, unlike danazol and some other progestogens. The Indojava is present in the market. We all know that there are 3 products present in the market at the time being. We have difficulty finding other brand names. The good thing about this medication is that it is available. Thank you very much.
Thank you very much, Dr. Amr, Professor Amr, for this lecture. I would like to thank all the speakers, chairpersons, and audience. And this first session is finished. Thanks God. Bye.